This conference will now be recorded.
All right, so we're going to cover Chapter 15, Respiratory Emergencies. This is probably one of the most common calls we're going to go on during certain times of the year. So more towards the fall and because of the change in weather and seasons. And respiratory calls really start at the EMT level. And what they've done with EMT level for Maine and New Hampshire, they've really given you guys a good scope of practice to treat these patients before the paramedics and advanced EMTs come on board, which is phenomenal to see that. So obviously we're going to follow the EMS standard competencies with medicine, applying fundamental knowledge based on the assessment findings for the acutely ill patient. With that, we have to learn anatomy and physiology. So we've kind of hit this, maybe, there we go. So we've kind of covered A&P already. So this should be a lot of a review for you. So anatomy and signs and symptoms and management of respiratory emergencies, including those that affect the upper and lower airway. And there's going to be a lot of things, even at the EMT level, that we can handle upper and lower airway respiratory emergencies. And a lot of times, a lot of these respiratory issues can be medical as well. So we'll talk about the use of epinephrine along with working with albuterol treatments and things like that to kind of open and bronchodilate, along with vasoconstriction, which will help in the sense of an anaphylactic reaction. We're also going to talk about epiglottitis, which you're going to see a lot of the times in kids. Very, very dangerous, severe condition in pediatrics. Let's talk about a collapsed lung, pulmonary edema, so fluid buildup in the lungs, asthma or asthmatic patients, then chronic obstructive pulmonary disease, otherwise known as COPD, and how we're going to be able to treat these in the field. We're going to talk a little bit about environmental and industrial exposure, toxic gases, pertussis, cystic fibrosis, and pulmonary embolisms, pneumonia, and any kind of viral respiratory infection. Again, I'm not going to be this on COVID. You guys have learned this and seen enough about this on news media, fire departments, and everything else. So I'm not going to hit too heavy on COVID response. I'm pretty sure we have that down. Just remember that it is ramping up again, and just be ready. It's not going to be as severe, but people are still getting sick. I still see a lot of the statistics that are there. And just to kind of make a little mention, yesterday there were 311 new cases in Boston. Yesterday, Maine had the other day 114 hospital. 14 out of the 114 patients were in the intensive care unit. Out of those 14, only 2 were intubated in the entire state. So as you can see, it's starting to kind of wind down a little bit, but people are getting vaccinated. So with that, it's reducing the stay in hospital, also reducing some of the symptoms. Not saying it's guaranteed, but we're starting to see that hospital stay reduced because of that. All right. So with patients often complain of dyspnea, so shortness of breath or difficulty breathing. When we're doing our assessment, we kind of need to make sure that we are assessing that dyspnea. By doing so, we look at what they call word dyspnea, and that is when a patient, how many words can a patient speak in between breaths? If they only can speak 1 to 2, maybe 3 words, these are our critical patients. Okay, we really can't have. They're unable to get that breath in, therefore they're more oxygen saturation will start to drop, and therefore hypoxic. And these are patients that are critical that we need to make sure that we get faster treatment. If they're saying I'm short of breath and they're speaking in full sentences, we got a little time to play. We got to figure out why they feel short of breath, and it could be because they have a little bit of fluid in the base of their lung. It could be something with pneumonia that's not progressively getting worse at that point in time. Other things that could cause dyspnea as well would be like the common cold. And one of the things we're seeing a lot more of now in the field, everybody was wearing masks, prevented us from getting flu was almost non-existent in the winter of 2020 to 2021. We just didn't see patients with the flu. Working in the emergency department, I may have seen one patient that had a diagnosis of a flu. Other than that, it was COVID. So people stopped getting flu vaccines. Because of that, now that retired and we're starting to wearing masks. Masks are no longer required. See, we're getting a very late flu season. Because of that, people are getting very sick, and they're getting diagnosed with influenza A or influenza B versus COVID-19. So still wear a mask, still protect yourself. Other things would be like asthma, heart failure, or a PE or pulmonary embolus. And I'll tell you guys a story about pulmonary embolus with a patient I had years ago. Dyspnea can be difficult to determine what's really going on. Whether it be pneumonia or CHF, things like that, we're still going to be treating the patient a lot of the same, utilizing CPAP, which we'll talk about a little bit later. Several different problems may contribute to a patient's dyspnea at the same time. So it could be like a pneumonia that exacerbated COPD. So they could have two different diagnosis. You still may be able to save a patient's life. And let me tell you, bringing CPAP down to the EMT level was a game changer for patient care. Sorry, Nick, which last sentence did you not get?
The one right before CPAP.
All right. So I'm trying to go back and remember what I said there. So there's different problems that may contribute to a patient's dyspnea at the same time. With that, it could be like a pneumonia that exacerbated a COPD patient, which made them get worse. You could have two different diagnoses, but may require very similar treatment. So even without a definitive diagnosis, you still be able to save a patient's life because of that, right? Because shortness of breath is still shortness of breath. How we treat at the EMT level, up to even the paramedic, some variations at the paramedic level. So with that being said, like I said, a lot of stuff happens and starts with basic level care. Respiratory systems include all the structures that contribute to breathing. So your diaphragm, your chest wall muscles, accessory muscles of breathing, signs. We're going to look for that. We're going to see in a patient that's in acute respiratory distress. We'll see accessory muscle use. And then nerves from the brain and spinal cord to those muscles as well. So we're going to see that accessory muscle use. We're going to see pursed lip breathing. We're going to see tripoding, things like that we're going to be able to pick up on. So a little bit of review. The upper airway consists of all anatomic structures. Nose, mouth, your jaw, your oral above the vocal. So that would be your nose and cavity, your pharynx, and your larynx, which is the end of the upper airway. I'll show you guys a picture in the next slide. As you can see here, the pharynx, the mouth, the epiglottis, and the larynx. This is your upper airway. Once you get to the trachea down, where you talk about your bronchioles and your main bronchi going into the pulmonary capillaries, this is all lower airway. All right. So we do have some upper airway stuff we're going to deal with, and one of the ones we'll see will be epiglottitis, asthma, COPD, croup. Stuff's going to be your pneumonia, CHF. Those are all going to be a lot of your lower airway diagnoses that we're going to be treating in the field. Pulmonary embolus, another one as well. The principal function of the lungs is respiration. Remember, exchange of oxygen and carbon dioxide. Air has to come in, it goes round and round in the system, right? And it comes back out as a gas, off gas as a carbon dioxide reading, or we can measure that. So comes in, we breathe air in. It travels through the bronchi, into the bronchioles, into the alveoli. At the alveoli, that's where your deoxygenated blood comes back, taking all those toxins, comes back through into the alveoli. We expel the carbon dioxide as we're breathing in. New oxygen comes back in, attaches to the red blood cells. Red blood cells then transport it throughout the system. Okay, it transports through the the arteries, and the arterioles, into the capillary beds. Remember, it's a gas, so it's capillary beds. We have some gas exchange that happens there and through diffusion, right? And with that, and then it goes back into the venules, into the veins, back around into the right atrium, to the right ventricle into the lungs, to the alveoli, and then we start getting our gas exchange. Knowing the drop of blood and how the blood flows through, you're going to see this stuff on your exams. You're going to see that on your National Registry exam as well. All right. So understand how that works. Now, there is a way that we can also measure carbon dioxide or off-gassing. That's what we call end-tidal carbon dioxide or end-tidal CO2, where we can measure it through nasal cannula and through what they call mainstream, where we can actually put it onto a BVM as we're ventilating somebody through a bag valve mask. We can actually monitor that. Or if the patient's intubated, or at the EMT level in New Hampshire, you're going to be placing King Airways or a super airway above the glottic opening. So they call it supraglottic airway, which will teach you guys on one of your practical days that we have and how to place those airways through a skill lab. So respiratory process, remember, is inspiration, expiration. These are two processes that occur. So inspiration is the act of breathing in or inhaling. Expiration is the act of breathing out or exhaling. Oxygen is provided from it. So in healthy lungs, this exchange of gases takes place rapidly at the level of the alveoli. Healthy lungs. The change is going to be when we have a disease process that blocks that, whether it be asthma or buildup of mucus, chronic bronchitis, emphysema, your COPD patients, pulmonary edema, fluid building up like you're drowning internally, a pulmonary embolus due to a blockage, having emboli. So these are different things. When we start throwing that into the mix, then we don't have the healthy lung anymore. And then we're going to have to start making those treatments. So as you can see here in the picture at the cellular level, breaking stuff down, oxygen comes in through red blood cells, right? And it gets transported around, and then it's dropped back off, and deoxygenated blood comes back around with carbon dioxide and off-gassing. Now, if we have issues with the alveoli, okay, our alveoli have to be able to expand and contract. They have to be able to open and close, like bigger, smaller, bigger, smaller. What we don't want is to have those alveoli collapse. Okay, if they are collapsing, which we're going to get to in a little bit, but I'll give you the name of this. It's called atelectasis, and that's when your alveoli collapse, therefore no longer can function to have gas exchange. Another thing that helps is that we can call it surfactant. If you spend some time in the OB ward, you'll hear about surfactant levels and things like that, and they kind of help out by giving the infant surfactant to kind of help expand those lungs and the alveoli itself. But beyond that, into what we're dealing with now, if we reduce surfactant, our lungs can no longer oxygenate appropriately, therefore we'll have atelectases, and we'll start having alveolar collapse. All right, so let's talk about the alveoli. So the alveoli lie against the pulmonary capillary vessels. So oxygen then passes freely through the tiny passages in the alveolar wall into these capillaries through the process of diffusion. Remember, area of lesser concentration, area of greater concentration. Is then carried to the heart, which pulls through. It then pumps oxygen throughout the body. Carbon dioxide returns to the lungs. It diffuses back to the alveoli and travels back up the bronchial tree, and it exits through the upper airways during exhalation. All right. The brainstem will then sense the level of carbon dioxide in the arterial blood. With that, if the level of carbon dioxide drops too low, with the brainstem at a slower rate and less deeply. Sensing this, the person will automatically, to help offset that to meet homeostasis. As a result, less carbon dioxide is expired and the levels of the blood return to normal. If the level of carbon dioxide rises above normal, the person breathes more rapidly and more deeply. With that, more carbon dioxide diffuses out of the bloodstream and levels of the blood then return back to normal. They are lowered. Now, if we have a brainstem injury for this, our body's not able to compensate. These are why patients that have brainstem injuries or patients that are then like come out of cardiac arrest, or if they have patients with like severe COPD or things like that, or if they have like a toxin that's been involved, that can inhibit the patient from actually breathing and having the brainstem function with those appropriately. All right. We have to be able to assist with our patients, and whether be using a BVM to help them breathe, help to get oxygen in there. And that's how we make that change. So a little bit about pathophysiology. So the proper exchange of oxygen and carbon dioxide can be hindered by abnormal or pathologic conditions in the anatomy of the airway, through a disease process, traumatic conditions, or pulmonary vessels, which may have abnormalities that interfere with blood flow. So you must be able to recognize the signs and symptoms of inadequate breathing. We have to be able to pick up on this. If they're breathing too fast, if they're breathing too slow, if they're breathing irregular, we have to be able to pick up on that rate. So remember before when I talked about doing assessments, we look at not just rate, but rhythm and quality of the breathing. Is it rapid, shallow, slow, labored? What's the quality like, right? What's the rhythm like? Is it regular rhythm? In and out? Is it irregular, like a patient who's in diabetic ketoacidosis, right? Is the rate too fast, too slow? Too slow be less than 12, too fast be greater than 20. Keep in mind, we're talking about adults, okay, not pediatrics or anything else. Or not infants, pediatrics, or child. We're dealing with adults only at this point in time with numbers and rates. So know what to do about it. Carbon dioxide retention and hypoxic drive. Right? So patients will sometimes have an elevated level of carbon dioxide in their arterial blood. Potential causes of this would be exhalation process may be impaired by a lung disease. The body may naturally produce too much carbon dioxide. If levels stay high for a period of years, the respiratory center in the brain may not function properly by a chronic carbon dioxide retention. This could significantly in this patient. And we're going to see this kind of stuff in patients that are like COPDers, like usually like the emphysema patients. And what will happen is you'll start seeing an increased AP diameter of the chest. You'll see more of like a barrel chest. So those of you who have seen as part of the assessments already, if you have a patient that's a pretty bad COPDer, a lot of times you'll see that increased diameter, what they call AP diameter of the chest, which we'll talk about in a little bit. The brain gradually accommodates for high levels of carbon dioxide and then uses a backup system to control breathing based on low levels of oxygen, known as the hypoxic drive. So use caution when administering oxygen to these patients. Sorry, plane flying over. So what they're talking about here is those COPDers, the ones that live at a low oxygen level. And I don't mean like in the 60s and 50s. I'm talking about 90, 91, 92. And that's where they live at a normal basis because their lungs and have been running that hypoxic drive for so long that their body get used to living at that level. Now, long-term high flow oxygen on these patients are going to be detrimental to the patient and actually do more. Short term, if you bring their arm, then good. Oxygen levels up to 98, 99% on a short-term basis, that's perfectly fine. It's not going to hurt them. It's the long-term stuff, but short-term is okay. All right, so causes of dyspnea. So the causes of dyspnea can be caused by many medical problems. May not be alert enough to complain about it. Therefore, they'll have altered mental status, which may be a sign that the brain is dysfunctional because of severe hypoxia. So we have to look at different signs and symptoms of those, and some of them would be looking at cyanosis. Are they turning blue? Other ones would be utilizing your pulse oximetry levels. So is it less than 94%? So patients often have difficulty breathing or hypoxia with the following medical conditions. We'll cover those here: pulmonary edema, hay fever, pleural effusion, obstruction of an airway, hyperventilation syndrome, environmental or industrial exposure. We'll talk about like black lung, things like that back in the coal mine days. Carbon monoxide poisoning. If you put a pulse oximeter on a patient, you're still going to see high readings and think the patient's perfectly fine when they're really not. Right? So we have to measure SpCO, and a lot of the cardiac monitors we have now have something called a rainbow cable that can monitor SpCO on a patient. However, they also make something called like a RAD 57 machine, which is like a pulse oximeter. They'll give you actual CO numbers. So there's a good tool with these changes as well. Obviously, a drug overdose can also cause a lot of these. So be aware that one or more of the following situations may exist in a dyspneic patient. 1, gas exchange between the alveoli and pulmonary circulation is obstructed by a fluid in the lung, an infection, or collapsed alveoli, which is called atelectasis. All right, so we could have an infection like a pneumonia, fluid in the lung, which is more like a pulmonary edema, heart failure causing fluid to build up in the lungs. The alveoli then are damaged or cannot transport gases properly across their own walls. 3, the air passages are obstructed by muscle spasms, mucus, or weakened floppy airway walls. Blood flow to lungs are obstructed by blood clots. That'd be more like your PE, pulmonary embolus. Or the pleural space is filled with air. So lungs cannot properly expand like a pleural effusion. So I'll show you guys this slide here. On my screen, it is so small that I can't even read it. But this table shows signs and symptoms of inadequate breathing. I'll leave it here for you guys to read really quickly. I honestly just I can't see it on my screen. It's too small.
You can hear all the sounds of nature in the background.
I know it's a be an interesting lecture. You went till
It's a
night.
very relaxed.
I hope I don't put you guys to sleep then. All classes are this way. So we got to make sure we're looking for actually the causes of dyspnea, but the more like the classic signs we're going to see. And the biggest ones we're going to watch, if you walk into a room and you see them tripoding and they're pursed lip breathing, we know these patients are sick. These are patients that need help breathing, right? And we'll talk about CPAP with this in a little bit and how we can help these patients with continuous positive airway pressure, providing PEEP, which is positive and we'll be able to help these patients out with this. And then I look at CPAP like giving somebody sugar who's a diabetic, has hypoglycemia, low blood sugar. It fixes them. You know, CPAP is like D50 or oral glucose. It works quickly with these patients, and it can turn a patient around and keep them from being intubated. The last thing we want to do, and yes, I am a paramedic speaking this way, a lot of bad things can happen with this, okay? And especially if they're elderly, will they be able to come off a ventilator and be alive? A lot of patients have a hard time coming off vents. So we can give them that crutch and we can help them with CPAP at the EMT level. Absolutely. If that prevents them from being intubated, that's what we want to do, right? So look for those signs and symptoms and treat respiratory patients early because they can only maintain so long toxic, more unstable before they become more hypoxia, right? We can't sit around and say, well, do we want to do, if you have a gut feeling this patient needs CPAP, then put them on CPAP, right? If you have a gut feeling they need albuterol or duoneb, then give them that, right? Just make sure you check for allergies first. If they have an allergy to albuterol or a soy products for duonebs, then you don't want to give that, obviously. So again, treat your patients, right? Wait to get to the ambulance and put somebody on CPAP. That's 5 more minutes, 10 more minutes of a patient that can't breathe. And if there was any one of you guys in the class right now that couldn't breathe, you'd want me to fix you right away, not wait 10 minutes to get something on you to help you breathe, right? Right. So I tell people this all the time: bring the equipment inside with you. Please bring it in and treat your patients. All right. So some other causes of dyspnea: patient may also complain of air hunger. Right. So they may develop chest pain or chest tightness because remember, if they're not oxygenating appropriately, their heart can only take it for so long before they start developing some chest pain. You'll see that chest pain, shortness of breath. Well, is it shortness of breath that caused the chest pain, or did the chest pain having a blockage somewhere cause more of the shortness of breath? That's something you have to figure out based on your assessment. Dyspnea is a common complaint in patients with cardiopulmonary disease, which we're going to cover on the next chapter. It causes the heart to pump inefficiently and deprives the body of oxygen. If we have a patient who has pulmonary edema or acute pulmonary edema, or called APE, these patients have a left ventricular failure, left-sided heart failure. Therefore, the blood or fluid is now backing up into the lungs. All right, these are critical patients. These patients need CPAP. They need to be potentially on nitrates, which you cannot give. These are patients you want to have paramedic level care. If you have a patient who's in congestive heart failure with pulmonary edema. Severe pain can cause a patient to experience rapid, shallow breathing without the presence of a primary pulmonary dysfunction. Right? If they're in a lot of pain, they're going to start hyperventilating. Hyperventilation can cause people to pass out. We talked about that before, right? Because they're not retaining enough carbon dioxide and oxygen on that exchange. So therefore, it's going to cause them to pass out. There we go. So upper and lower airway infection. Infectious diseases may affect all parts of the airway. We're going to get into those more in detail. All right. Some can cause, so upper to lower airway have mild discomfort. Some require aggressive respiratory support. We'll talk about those here in a second. Oxygenation is a problem of inadequate oxygen delivered to the tissues, right? So we got to make sure that we can help that oxygen delivery. The problem causing dyspnea always comes from some form of obstruction somewhere, whether it be mucus and secretions obstructing airway and major passages, swelling like epiglottitis or croup, impaired exchange of gases in the alveoli like pneumonia. So be diligent about the use of appropriate PPE and when in contact with patients who have infectious disease, right? Because one of the things that we've kind of gone away from with protection is we forget about tuberculosis. We've been so tied up on COVID that we forget about TB. So let's talk about croup. Or swelling of the pharynx. So croup is an inflammation of the pharynx and trachea, typically seen in children between 6 months and 3 years of age. Easily passed between children, and one of the hallmark signs of croup are stridor and a seal bark cough. Croup often responds well to the administration of humidified oxygen. We do not carry humidified oxygen in the ambulance, but what you can do as an EMT is a nebulizer and have them use that. It's within your scope of practice to do nebulized saline. It's not a medication. Well, it is, but it isn't. But they need a humidification to kind of bring that down. So a lot of times what they'll do, you'll get called for a respiratory distress pediatric. when you get there, they say, yeah, you sound like a seal barking. Okay. What do you find? It's because you're standing outside in the cold. That's constricted the air, constricted the vessels in the airway, causing better airway passing. Or they'll take them into a hot shower and allow that humidification to get into the lungs, into the airway, and reduce that swelling. It doesn't mean that it's over. When they get back inside again, it could potentially come back. All right, so just be aware of that. Do you hear that stridor or bar cough? It's upper airway obstruction, upper airway disease, and it might potentially have to be treated. If they're perfectly fine, they're crying, and they're doing okay, then we really don't need to call for ALS care for these. Okay, but if they're having more of an obstruction, they may need something more progressive. And that's going to be nebulized epinephrine. So that's a paramedic level skill. So if croup is not being dealt with, if you no longer can deal and handle what's currently going on and it's getting worse, then call for ALS treatment fairly quickly, whether it be racemic epi or a nebulized epi. Epiglottitis, this is very dangerous in kids. So this is an inflammation of the epiglottis, so the little punching bag sitting on the back of your throat, usually as a result of a bacterial infection. More predominant in the children, but can also occur in adults. I've had cases with this with pediatrics. Usually develop suddenly, and the children look very ill. They report a very sore throat and have a very high fever. Often found in the tripod position and drooling. So that's going to be your key thing right there, is the tripoding and the drooling. The best treatment for this is get them to a hospital. There is nothing even a paramedic is going to do for a kid with epiglottitis. All right. Treat the children to make them crying can cause more irritation and more inflammation to the point where the airway actually closes up and they can no longer breathe. So position comfortably, provide high flow oxygen, and do not put anything in their mouth. Do not do anything. If you can't even get a set of vitals on these patients, it's okay. Do your best to get one, but you don't want to irritate them so they start crying. Because once they start crying, it causes more irritation. So keep that in mind. Epiglottitis, get them to the hospital. So Nick, it can at some point in time. To answer your question on can croup cause airway obstruction, yes. So now I'll mention this too. So on an X-ray, what they're going to do is they'll do an X-ray of the trachea and the upper airway, and they'll look for something called. So think of a steeple on top of a church. How it starts off wide and gets very narrow. That's croup. So you can start with a very wide airway. As it narrows in like a steeple, what will happen is eventually that can close right up. So having that that nebulized airway back up again. And if that's not working, that's where the paramedic comes in and they can give racemic epi. And they can do nebulized epinephrine to help open up that airway even better. That answer your question, Nick? Awesome. Croup is very common. I've been to a lot of croup patients. And a lot of times I end up giving racemic epi to them. So RSV, respiratory syncytial virus. Yeah, and so how did you treat that, Nick? You feel free to jump on if you want to talk about that. How did you handle that at home?
Yeah, the first time it happened, we were spooked. It was really scary sounding. Even having been, a first aider and an EMT in the past, I was not aware of it. And we did got him outside, and it went right away. It was in the winter, and it was amazing the impact that the cold had on it.
Yeah.
That was a relief. How quickly it subsided.
Yep, it really
I wasn't aware that it could
Yeah, it
actually
helps.
become a true respiratory obstruction. So that's a good thing to be aware of.
So a lot of times it's perfectly fine, but you get those other cases, and I've said I've had a handful of cases where I've had to give epinephrine to these patients. But again, humidified oxygen, things like that, that does help with these, or the cold. Get outside in the cold. We're very rare. Are you going to see croup during the summertime? Usually, it's more of a winter deal. So you start seeing that changes in temperature from the hot to cold, and that's when we start seeing croup. So let's talk about RSV for a little bit. So respiratory syncytial virus, with this can cause an infection in the lungs and breathing passages, which is highly contagious. So when we do swabs, we actually check for RSV. We're not going to do that. Obviously, I did that in the emergency department. We're not going to see that in the field. But we used to do something called a fourplex check, which checked for RSV, flu A, flu B, and COVID. It was a fourplex, we called it. But they do have an RSV swab. All they do is they go in through the nose, just like they would for the COVID swab, and they send it to the lab to see if they have RSV or not. What we're going to look for, though, as long as it's highly contagious, make sure that you're protecting yourself. Look for signs of dehydration. Remember, in infants with dehydration, we look for the fontanelles if they're neonate infants. So they have sunken in fontanelles. Remember, that is dehydration for them. More of a late sign, but they are dehydrated. Other than that, look for white coating of the tongue, tenting, skin, things like that, blood vital signs, and then treat for dehydration. Treat the airway and breathing problems as appropriate. Humidified oxygen is also very helpful. If you notice in these pediatric cases we're talking about, a lot of it's humidified O2. Bronchiolitis is a viral illness that occurs due to RSV, usually newborns. Bronchioles become inflamed, swell, and fill with mucus. To provide oxygen therapy, frequently reassess for signs of respiratory distress. Again, treat them with oxygen. If we have to ventilate, we have to ventilate. But until then, it's just treat with oxygen and get them to the hospital. There's not a lot we're going to even do at the paramedic level, but just get them to the ER. Pneumonia, which is a bacterial, bacterial pneumonia first, will come as a result of a fever. So the general term refers to an infection of the lungs. That's pneumonia. Often a secondary infection that begins as an upper respiratory tract infection. Can be caused by a virus or bacteria, or by a chemical injury or direct lung injury. So we talk about direct lung injuries, right? Patients that have rib fractures, patients that have been intubated or coming off being intubated, traumatic patients can get pneumonia as well, because not a lot of tidal volume can leave a lot of higher, dead space. Doesn't allow you to ventilate appropriately. By doing so, you have a lot of that stale air that stays in your system, and that can cause pneumonia. Other ways of getting pneumonia as well would be something called aspiration pneumonia. So patients that vomit or something goes down their airway causing significant pneumonia. I'll tell you a story about that one here in a second. Pneumonia will come on quickly because the result of high fevers. Viral pneumonia presents more gradually and less severe. Right? Viral pneumonia not contagious. Bacterial pneumonia can be contagious. Signs and symptoms of this would include rapid or labored breathing in children, blue or gray lips or fingernails, fever, dry skin, decreased skin, dyspnea, productive cough. So these are questions you want to ask the patient. Have you been coughing? Has anything been coming up? What color was it? Chest discomfort and chest pain. And keep in mind, just because they have chest pain does not mean that it's cardiovascular in nature. It could be a pneumonia. It could be from the persistent coughing as well. Headache, nausea, vomiting, musculoskeletal pain, weight loss, confusion, or diminished breath sounds. So I had, and I'll tell you the story about pneumonia, very, very pneumonia at the point where I thought he actually had a collapsed lung. The patient had swallowed a tinfoil wrapper from a candy bar, and it went down his airway, which he failed to tell me initially. And he presented like he had a pneumothorax, like he had a collapsed lung. So I did a chest decompression, and all that came out of the guy's chest was pus, pus, and more pus. And just, it was a lot. So we ended up calling from the hospital. As I was transporting there, we called for DART and everyone inside. And I probably pulled about 400 mLs of pus out of this guy's lung. It was unbelievable. DART jumped on board, and they ended up putting a chest tube in. Yeah, so Deb mentioned that too as well. A lot of aspiration pneumonia for recovering from COVID. Yep. So again, these patients need to be treated. And one of the leading causes of sepsis is pneumonia. So what happens is that infection that's in the lungs becomes more, not viral, I'm trying to think of, becomes more persistent and gets into the bloodstream. And then we start getting something called bacteremia. Bacteremia then becomes like a full systemic response infection. So we want to make sure we're catching this stuff early and getting treated with antibiotics. Because if not, they turn into a septic patient, then we have a whole different ballgame to play with. So we got to keep an eye on that. Yeah, so Tondra just mentioned that as well. If you guys look at the chat box, didn't take long. An aspiration pneumonia. So something like pertussis. Pertussis or whooping cough is an airborne bacterial infection that mostly affects younger children, younger than 6 years of age, which is very highly contagious and is passed through droplet infection. Patients will be feverish and exhibit a whoop sound cough after a coughing attack. Coughing spells can also last for more than a minute, during which the child may turn red or purple. As the hydration, suction as needed, and then pertussis in adults can cause a severe respiratory infection. So you kind of want to pay attention for that as well. We don't see a lot of pertussis anymore, so people have been vaccinated for it, but it's still out there. Influenza A became a pandemic in 2009. In 2009, the H1N1 strain of influenza type A became a pandemic or an outbreak that occurred on a global. We're seeing more influenza now because people are not, we didn't get the vaccines I talked about earlier. Symptoms include fever, cough, sore throat, muscle aches, headaches, and fatigue. My goodness, it sounds like COVID. Right? So we got to still treat it. Wear a mask, wear your N95 if people have influenza, protect yourself. This may lead to pneumonia or dehydration. Another airborne disease called tuberculosis. Before you started clinicals. This is best for me to make sure you don't have it currently, never had it in the past, and it's also required on a yearly basis to get tested. Simple implantation under the skin within 48 hours. If it circles red and blotchy, you've had TB before. Then they send you in for a chest x-ray, and if you clear the chest x-ray, you're good. If not, and there's nothing there, you don't have TB. This is the bacterial infection that most commonly affects the lungs. Mostly people that travel third world country and come back over. It's people that have gone on mission trips, things like that. They kind of help out other third world countries to come back with tuberculosis potentially. That's why you need to get tested. It's also going to be found almost any other organ. Could also remain inactive for years before producing any types of symptoms. Patients often complain of fever, coughing, fatigue, night sweats, and weight loss. And with severe infection, patients will experience short breath, coughing, productive sputum, bloody sputum, and chest pain. So prevalence is very higher in the homeless population, prison inmates, and nursing home residents. TB is also found in people who abuse intravenous drugs or alcohol, or those with HIV. So if you suspect a patient to have TB, you should wear, at a minimum, eye protection N95 respirator. Minimum protection. So I wear again with patients with TB. All right, so acute pulmonary edema. Sometimes the heart muscles cannot circulate properly. The left side of the heart cannot remove blood from the lungs as fast as the right side delivers it. Therefore, it builds up within the alveoli and in the lung tissue. This accumulation of the fluid then is referred to as pulmonary edema. Usually results from congestive heart failure. So patients who experience shallow aspirations in severe cases, a frothy pink sputum forms at the nose and mouth. If we see this, you need to get ALS on board as quick as possible. These patients need to be sedated, paralyzed, and intubated. If they start seeing pink frothy sputum, that means that their airway is almost completely closed up with fluid. Most patients have a long-standing history of chronic congestive heart failure that can be kept under control with medication. All patients with pulmonary edema have heart disease either. Things can change. Even heart attacks can cause pulmonary edema as well. Inhaling large amounts of smoke or toxic chemical fumes, traumatic injuries to the chest, and exposure to high altitudes can also produce pulmonary edema as well. These are patients that need continuous positive pressure to push this out. If you're to the point where the patient is not very to be able to maintain their own airway, then CPAP is now contraindicated, and we need to utilize a bag valve mask, and we need to push that fluid out of the lungs into the interstitial spaces. As you can see here with fluid buildup. So now we're trying to build up fluid. Basically, you're drowning internally. All right, so COPD, what common things we're going to respond to? All right, so those common things are. So COPD is a slow process of dilation and disruption of the airways and alveoli caused by chronic bronchial obstruction. So with that, COPD is an umbrella term used to describe a few lung diseases, including emphysema and chronic bronchitis, which is an ongoing irritation of the trachea and bronchi, which may result as a direct lung and airway damage from repeated infections or inhalation of toxic gases or particles. This is most often a result of cigarette smoking. So remember, tobacco smoke is a bronchial irritant and can create chronic bronchitis, which is an ongoing irritant of the trachea and bronchi. With bronchitis, excessive mucus is constantly produced, causing small airways in the alveoli. So we're seeing that mucus blockage. Therefore, we can't get the most appropriate gas exchange. Airways are then weakened as the lungs' protective devices are now destroyed. The chronic oxygenation problems can also lead to the right-sided heart failure and fluid retention. We start seeing extremity edema. Pneumonia develops easily, and repeated episodes of irritation and pneumonia in the lungs and some dilation of the obstructed alveoli leading to COPD. So patients that have COPD will have something known as what they call a shark fin waveform, which we're going to see on the end tidal readings. And that's because if we all take it, if everybody in the room does not have COPD in the classroom, right? We all take a deep breath in and we exhale back out again. We're going to see a normal waveform. Plateau, all our alveoli are exchanging gas and pushing carbon dioxide at the same time. We have blockages in there, like mucus blockages and things like that. What you're going to see is that our alveoli, as we exhale, is going to push out carbon dioxide in like a wave versus a straight up and plateau off as like one exhalation. Takes a little bit longer, causing what they look like a shark fin. Picture a shark fin as you're exhaling. The carbon dioxide doesn't get all released at the same time. It comes off in a wave. So that's where that. Patients that have COPD or emphysema is the most common type. What we're going to see is emphysema is the loss of elastic material in the lungs as a result of chronic stretching of the alveoli. Therefore, we're unable to get that proper gas exchange. Smoking can directly destroy the elasticity of the lung tissue. Most patients with COPD have the elements of chronic bronchitis and emphysema. So most patients will chronically produce sputum and have a chronic cough and have difficulty expelling air from their lungs, which long expiration phases and wheezing. If this is getting worse, then we have what they call an exacerbation. So an exacerbation is when that patient gets more obstructed and they need something stronger than the normal albuterol. So they may need CPAP to help put the lungs better on the alveoli, providing better positive end expiratory pressure, which is PEEP. Now, when we normally breathe, okay, our vocal cords help provide PEEP. If we lose that function, we have no longer PEEP, it's very hard to breathe. All of us in the class right now have a PEEP of 5. If we have a patient with COPD exacerbation, we need to provide a higher PEEP, maybe up to 7.5, 10, 12.5, 15, 20, all right? We have to increase the PEEP on a PEEP valve, which is located on our CPAP devices, to provide higher positive end expiratory pressure to allow the alveoli to stay open a little bit longer for better gas exchange and oxygenation, all right? That's why it's so important. And then we introduce a bronchodilator, which is going to be our duoneb, which is at the EMT level now. We can what they call inline neb these patients by doing bronchodilators with CPAP, pushing that medication deep into the lungs to help for that bronchodilation, to help for that better gas exchange. Does that make sense to you guys? All right, we'll see. Perfect. All right, so Deb, so I'm going to have you try something if you can hear me okay. Take a deep breath in and out with your mouth open. Okay. In and out, right? Okay, now purse your lips like you're trying to kiss somebody. Take a deep breath in and breathe back out again with pursed lips. Okay. Which one allowed you to take a longer exhalation? Mouth open or mouth closed? So when you open your, so pursed lips, right? The pursed lips, bringing in like a kissing movement, exhaling, breath coming out, will take longer than when your mouth being wide open, right? Okay, that is called PEEP. It's positive end expiratory pressure. So it's end expiratory pressure, positive pressure against it. So when you purse your lips, you're having end expiratory pressure, positive end, coming out, allowing for your lungs to stay open a little bit longer. And that's why you have people that have COPD have pursed lip breathing. What we're going to do with CPAP is CPAP for continuous positive pressure, right? We're going to apply the mask on their face, and then we're going to increase the PEEP. So that way there, when they breathe out against the mask on their face, that positive end expiratory pressure from the continuous positive airway pressure that's being given keeps the alveoli open longer. We can change the normal PEEP of somebody by applying a mask with pressure behind it. All right, perfect.
Pretty much having pressure on both sides.
Yes.
Is that what, that's what you're saying? We're having pressure on both sides with the CPAP.
So CPAP is continuous positive airway pressure. BiPAP or bi-level pressure is different than CPAP. So we have the same, so we have the pressure coming in, the oxygen, right? But really that CPAP or pressure coming in provides for positive sides of that PEEP versus BiPAP, which has inspiratory pressure and expiratory pressure. So when you inhale in, it pushes more air in. When you exhale out, then it also backs up against it. If you have bi-level pressures versus a patient that only has CPAP on, which is only positive and expiratory pressure or continuous expiratory phase. Does that make sense? Positive pressure without that, it only has an expiratory. That makes sense? I think it was Dave that was talking, right?
Yeah, it was me, but it makes sense. You were breaking up a little bit, but it makes sense.
Okay. So ambulance. So New Hampshire, Maine does not allow this yet for paramedics, but New Hampshire does, and we're allowed pressures that you can use through ventilators on an ambulance bi-level pressure task. So the next time, if anybody rides with me, we have a ventilator in TANF, and I can show you guys how BiPAP actually works. And I can actually show you guys in the next class. I mean, it's not something you can give, but it's pretty cool to see. And not a lot of medics know how to set that up, but it's fairly simple to do. So Deb, you have BiPAP and didn't know the difference. Yeah, there's a definite difference because one has two different levels, inspiratory and expiratory, versus CPAP, which only has expiratory phase. Tandra, to add to yours, so BiPAP adds inspiratory. It's what they call IPAP, IPAP, versus EPAP, which is expiratory pressure. So BiPAP has two levels, which adds in inspiratory. CPAP only has expiratory. Tandra, to answer your question, Maine does not allow ventilators on ambulances for paramedics, but New Hampshire does. So New Hampshire actually has a BiPAP protocol. So Deb, if you have a BiPAP machine, look at the settings, and you should see two settings on there: IPAP and EPAP. It's pretty interesting. All right, so let's keep going with the COPD. With that being said, patients with pulmonary edema will have wet lung sound, bronchi. So patients with pulmonary edema most often congestive heart failure will often have wet lung sounds or bronchi or crackles. The patients with COPD will often have a dry lung sound like wheezing. So wet lung sounds of pulmonary edema and the dry lung sounds of COPD can sometimes be confused. Do not assume that all COPD patients have wheezing and congestive heart failure have rales or bronchi. Patients with COPD may have wheezes that become, because of bronchoconstriction, present with shortness of breath, breathing gets progressively worse, having trouble breathing on exertion, have chronic coughing and thick sputum, and are usually long-term smokers with a thin barrel chest appearance. Often have a slower onset of symptoms as well. Patients with congestive heart failure experience a fluid overload in the lungs, which may develop quickly from a failing pump, so our heart failure. So asthma, hay fever, and anaphylaxis. Obviously, hay fever and asthma and anaphylaxis. Asthma, hay fever, and anaphylaxis result from an allergic reaction to an inhaled, ingested, or injected substance. In some cases, there is no identifiable allergen that triggers the immune system. Asthma is acute spasm of smaller airway passage, as you can see in the picture here. Mucus obstructing the bronchioles versus the normal airway. Asthma definitely affects all ages, most prevalent in children between 5 and 17 years of age, produces characteristic wheezing. Approximately 25 million Americans have asthma. Wheezing is indicative of a partial lower airway obstruction. Wheezing may be so loud that you can hear it without a stethoscope. So if you walk in and you hear it without a stethoscope, it's called audible wheezing. In other cases, the airways are so blocked that no air movement is heard at all. An acute asthma attack may be caused by an allergic reaction to a specific food or some other allergens. The attacks may also be caused by social distress, exercise, and respiratory infections, what they call exercise-induced asthma. In its most severe form, an allergic reaction can produce anaphylaxis. This may result in respiratory distress severe enough to lead to coma or death. Most patients with asthma are familiar with their symptoms and know when an attack is imminent. So listen to the needs of the patient. A lot of them know what's going on. Asthma cannot be, if it's treated and not getting any better with rescue inhalers. So they call status asthmaticus. These are very, very critical patients. One of the questions you want to ask the patient is, have you ever been intubated before? Hay fever causes cold-like symptoms. Allergens include pollen, dust mites, and pet dander. And so treat with epinephrine, oxygen, antihistamines. All right, let's take 5 minutes, and I'll come right back.
This conference will now be recorded.
All right, so let's talk about spontaneous pneumothorax. So pneumothorax is an accumulation of air in the pleural space. Is most often caused by trauma and may also be caused by a medical condition called a spontaneous pneumo. A lot of times you'll see spontaneous pneumos in, by statistical data, skinny, tall, white males. Based on statistical data, so more a little bit more about spontaneous pneumos. It's a vacuum-like pressure in the pleural space that keeps the lungs inflated. So when the surface of the lung is disrupted, air escapes into the pleural cavity, and the negative vacuum pressure is lost. Therefore, the accumulation of air in the pleural space may be mild or severe. Spontaneous pneumos occur in patients with certain lung infections or in young people born with a weak area of the lung. People with emphysema or asthma are at higher risk as well, and tall, thin, white males are also at higher risk. A patient with a spontaneous pneumo becomes dyspneic and might complain of pleuritic chest pain, which is a sharp stabbing pain on one side that is worse during breathing or certain movements of the chest wall. You can sometimes tell that breath sounds are absent or decreased on the affected side. So listen to lung sounds, and if they don't, if you are decreased, then it most likely is a spontaneous pneumo. A pleural effusion is a collection of fluid outside of the lungs, where it compresses the lung and causes dyspnea. It can be treated with caused by irritation, infection, or congestive heart failure or cancer, and the patient will start feeling better if they're sitting upright. There is nothing we're going to do in the field for a pleural effusion to help treat this. All right, they need to go to a hospital, and usually they get transferred out to a trauma center to take care of this. Obstruction of the airway. A patient with dyspnea may have a mechanical obstruction, so we want to make sure we treat this quickly. And in semi-conscious or unconscious patients, the obstruction may be a result of aspiration, a vomitus, or a foreign object, or improper positioning of the head, causing the tongue to block the airway. If the patient was just eating, or was eating just before the onset of the dyspnea, was considered a foreign body airway obstruction. So the obstruction of the airways you can see here, if they're unconscious, remember, based on AHA, we're going to be doing CPR. If they are conscious, we're going to do abdominal thrusts. Pulmonary embolus, or an embolus, or anything in the circulatory system that moves from its point of origin to a distant site and lodges there, obstructing the subsequent blood flow in the area. Circulation can then be cut off completely or partially. With an emboli, that can result in a serious life-threatening condition. We'll talk about some potentials that can cause this to happen. Emboli can be fragments of blood through the bloodstream, spread off and travel. So think of a deep vein thrombosis, DVTs. So, questioning you want to ask: long distance traveling, where patient may be sat in an airplane for 3, 5, 7 hours without moving, getting up, stretching, moving their legs around. By not moving, this can develop that. Excuse me. Recent surgery as well can also break off clots into the bloodstream as well. So you want to ask these patients if you've traveled in the last couple of weeks. Another one that can also cause PEs is a birth control as well. There we go. This may be a result of damaging to the lining of the vessels, a tendency for blood to clot unusually fast, or slow blood flow in the lower extremity, often a result of long-term bed rest. I'm going to pause this for a second because the plane's going over again. Hold on. Yeah, give me about 30 seconds. Sorry about that. I'm having some more connectivity issues here. Stand by. All right, can you guys hear me okay? I just reset my phone. Okay. Yeah, I was saying something about connectivity issues on my end. All right. So a pulmonary embolus. Signs and symptoms include dyspnea, tachycardia, tachypnea. So shortness of breath, rapid heart rate, along with rapid respirations. Varying degrees of hypoxia, cyanosis, acute chest pain, and hemoptysis, which would be like vomiting blood. So with large enough embolus, complete obstruction of the output of blood from the right side of the heart. So I remember I mentioned before about a call that I had gone on. I had a patient who was, 19 years old, and so I knew that it was a PE. I just by the signs and symptoms: chest pain, shortness of breath, frequent syncopal episodes, things like that. So I called for a medic. I was an intermediate at the time. We get in the back of the ambulance to Maine, and medic was being a royal pain in the butt and said, "You need to calm down. You're 19 years old. It's an anxiety attack. Stop crying and suck it up." That's what he told the patient. I couldn't believe he said that to her. So we get her to the hospital. He refused to do anything else. I put the line in, put her on a cardiac monitor. He's like, "This is an anxiety attack. There's nothing wrong with her." So I get to the hospital and I drop the patient off and I said, of an anxiety attack. And I said, so the nursing staff came in over the medic. I said, "This is not right. This is definitely a PE." They blew me off, which was surprising that they did, but they did. And they left the room, no monitoring. They just said a set of vital signs and walked out. And 2 minutes later, she goes, "I don't feel well." And she went into full cardiac arrest. 19 years old, full cardiac arrest. Came back in and said, "What happened?" I said, "I'm pretty sure it's a PE." So we got her back. Then she coded again, got her back again. And then that poor paramedic who decided to blow me off had to do a transfer with her to another hospital of higher level of care. And they pulled out a approximate 5-inch clot out of her lungs. She's alive to this day now. The thing is that she would have coded no weapon. I wasn't a patient advocate and stayed with that patient and would have known because she had no monitoring devices on her. They would have come back in a half an hour and found her dead. So again, patient advocate. If you see signs of pulmonary embolus, then you need to start treating it. Right? These patients here, there's not much we're going to do. Provide oxygen, get them to a hospital because these patients need it. Over breathing, to the point where arterial carbon dioxide falls below normal. Something that's very common in drownings as well, which is what they call shallow water blackout or hyperventilation. Maybe an indicator of a life-threatening illness, and the body may also be trying to compensate for acidosis or hyperventilation. But also this can happen to keep someone, if you want to stay underwater for a longer period of time, a lot of times they'll hyperventilate. Dioxide levels below normal, which allow them to stay underwater for a longer period of time. So this can result in alkalosis, hyperventilation as well, would build up excess base in the bodily fluids. And this can cause symptoms of panic attacks, anxiety, numbness, or painful spasms of the hands and feet, what we call carpal pedal spasms. Patients that are hyperventilating, even if it's anxiety that's causing this, what you'll start seeing is spasms or their hands start curling in.
Hey, Kevin,
Right,
I don't
so
know.
some environment.
Yeah.
What was that?
I said you disappeared for a few minutes.
Yeah, these planes keep going over and I'm trying to block the noise from you guys. Apparently it's a busy flight day. We're not too far from Myrtle Beach Airport, so it's just busy flight patterns today apparently. So environmental industrial exposure. So pesticides, chlorine, and other gases can be released. Carbon monoxide, odorless, remember, highly poisonous, produced by fuel burning appliances and smoke. So don't put yourself at risk. If you see people down, don't just put yourself in there because it could cause potentially dangerous issues. When it comes to pesticides and other things too, we'll talk about toxidromes during toxicology, so I'm not going to get into that now. All right, so looking at seeing size up, all right, you want to use standard precautions and PPE. So going to consider a possibility of infectious disease or toxic substance. Consider the mechanism of injury, nature of illness. Ask the question on why 911 was called. Question the patient, family, or bystanders to determine the nature of illness. You want to ask these questions to them, find out what's going on. This will help determine what's really going on with the patient. I'm going to reply back here really quick. Oh, of course it's not going to work. Flying back to a message. Stand by. All right. So one of the students messaged me on the private chat, so I'm going to get back to him really quick on an answer. All right, so identify immediate life threats. If you have a life threat, treat it. Okay, so airway, breathing, circulation, bleeding. Formal general impression, note the age and position of the patient. Are they tripoding? Are they accessory muscle use? Are they lying down? Are they sitting up, standing? Are they prone, supine, lateral, left to right lateral? Right, these are all things you want to pay attention to. Utilize the AVPU scale, alert to unresponsive. You want to ask the patient about the chief complaint. What is going on today? Why are we here? What made you decide to call 911 today? As far as airway and breathing, make sure the airway is patent with inadequate. We're going to assess rate, rhythm, and quality. If there's any question about the airway patency, it must be opened immediately using head tilt, chin lift, or jaw thrust maneuver. We're going to evaluate whether the patient's breathing is adequate. We're going to assess the rate, again, rhythm, and quality, and ask yourself the following questions. Is air going in? Does the chest rise and fall with each breath? Is the rate adequate for the victim's age? So if they're 55 years old and they're breathing 40 times a minute, that's a problem. All right. Now, if they're an infant breathing 40 times a minute, that's okay. And check breath sounds on the right. We're going to assess breath sounds. We're going to right and left side of the chest, as you can see here. Remember, don't go down one side than the other. You want to go back and forth, and check both sides to make sure they are equal bilateral. We're going to determine whether the breath sounds are normal or decrease, absent, abnormal. Are they rhonchi? Are they rails? Wheezing, stridor? Take a listen to all that. We're then going to assess circulation, evaluate for shock and bleeding. We're going to assess capillary refill in infants and children. We're going to assess perfusion by evaluating skin color and temperature and condition. We're going to reassess and identify any life threats in your patient. They would include any of the following signs and symptoms. Problems with ABCs: poor initial general impression, unresponsive, chest pain associated with this, potential hypertension with low blood pressure, severe pain anywhere, and excessive bleeding. We're then going to make a transport decision. If the patient's condition is unstable and there is a possible life threat, address the life threat and proceed with rapid transport. We're going to do some history taking. So we're going to investigate the patient's chief complaint. Objective and subjective observations are important in building a general impression of what's going on with the patient. Do they have any chest pain, any shortness of breath, dizziness, nausea, vomiting? We're going to find out the patient has done what the patient has done for breathing before the breathing problem. If they have a diagnosed issue like COPD or asthma, have they taken inhalers? Have they taken albuterol nebulizers? What are they taking for respiratory medication? What have they done to help with that? Different respiratory complaints offer different clues in the baseline status. With patients in respiratory distress, a sample history can be collected from bystanders or family if they are present. Be sure to ask the following about a patient in respiratory distress. What is the patient's general state of health? So are they terminally ill with cancer? Do they have pneumonia? What's going on with them? What's their general state? Has the patient had any childhood and any recent surgical procedure, adult diseases? Have there been injuries or hospitalizations? Have there been any traumatic injuries? And something else to add to that as well, have you been intubated before for this? Have you had a tube put down your throat to help you breathe? We're going to do an OPQRC assessment. Issue. When did the breathing problem start? This is your onset. What makes the breathing difficulty worse or better? That's your palpitation provocation. How does your breathing feel? That's your quality. Does the discomfort locate where my goodness. Where is the discomfort located and does it move? Radiation, much of the breathing problem, how much of a breathing problem is the patient having? Severity. On a scale of 0 to 10, how would you rate your breathing problem now? If the patient, if the problem is continuous or intermittent, if it's intermittent, how frequently does it occur and how long does it last? This is going to be your timing. So one of the new ones is the PACE assessment. So the PACE alternative assessment for complaint of shortness of breath or difficulty breathing. That one right over us. All right. So the PACE assessment is an alternative assessment for a complaint of shortness of breath or difficulty breathing. So PACE would be progression, associated chest pain, sputum, talking tiredness, excessive pressure tolerance. We're then going to perform a secondary assessment, more in-depth assessment of the body systems, looking at respiratory, cardiovascular, skin, blood pressure, neurologic, and proceed only after assessing or addressing your life threats. All right. So looking for signs of COPD. So is the patient older than 50 years of age? Now again, that doesn't mean everything. I've seen patients in their 40s and 30s have COPD, right? Depending on the conditions and everything else. Often have a history of lung problems. Patients that are very overweight can also have COPD as well, or like a pre-COPD, like getting into that phase. Often have a history of lung issues are almost always long-term active or former cigarette smokers. Complain of a tightness in their chest, constant fatigue, may have a barrel-like appearance. Remember I mentioned the AAP diameter increase of their chest, of the barrel chest. Often have use of accessory muscles to breathe and exhibit abnormal breath sounds. So what you may see with these patients are going to be like pursed lip breathing a lot. So if they're walking, they have to stop and catch their breath. They may purse their lips to provide that heat they're looking that they need. Then we're going to do our reassessment. So repeat the primary assessment, looking for any changes. Interventions may include oxygen via non-rebreather mask at 15 liters per minute, positive pressure ventilation utilizing BVM, or you may have continuous positive airway pressure or CPAP, which we'll talk about next. Airway management and techniques, positioning in a high Fowler's position or position of choice. Most of the time, patients that have shortness of breath do not want to be in a laying down position. They want to be in a Fowler position, high Fowler, like almost sitting up. And assisting respiratory medications like an albuterol inhaler or giving our nebulizers that we'll be giving at the EMT level for Maine and New Hampshire. Other emergency medical care would be administering of oxygen. Some patients may need CPAP. We talked about CPAP enough during this lecture here. We're going to be covering it again at some point with a different as well. The patient may have a metered dose inhaler, an MDI, and then consult with medical control to make sure that medication is in. The plane flew over. Contraindications with the patient able to coordinate inhalation. All right, so if they can't coordinate it, then they really can't inhale it. We have other methods of administering these medications, like an albuterol nebulizer. We can do it through a BVM and help administer it that way. Inhaler not prescribed to the patient. If it's not theirs, we cannot administer that. Permission not obtained from medical control. They tell you you can't do it, you can't do it. Or not permissible by local protocols. You have to learn your state protocols. Maximum dose already reached, the medication is expired, or other contraindications specific to the medication you're giving. So you have to know what the contraindications are for each medication. Most medications are used to relax the muscles that surround the air passages in the lungs. All right, so we have like albuterol, for example, or Duonet. We have the hypertrophic part of it, which is a steroid. And we also have the albuterol part of it, which is going to be our bronchodilator. It's going to help relax and cause bronchial dilation. Common side effects to inhalers, though, because they are a sympathomimetic medication, which means they mimic the sympathetic nervous system, causing that fight or flight response, which would be increased heart rate, muscle tremors, and nervousness. That is a common side effect of giving these meds. Right? So if you go from 70 to 90, it's okay. It's a side effect of the med. Now, if it goes to 180 for a heart rate in an adult, that's a problem. All right. Treatments of specific conditions, upper and lower airway infections. We want to administer humidified oxygen. We do not want to attempt any kind of suction in airway or place any so we want to keep the OPAs out. We want to position comfortably and transport promptly with these patients for specific conditions. Again, if it's a patient that has epiglottitis, we want to keep airway adjuncts out. So all we're going to do is irritate the airway, causing more problems. Acute pulmonary edema, 100% oxygen. We're going to need a suction if necessary. If we see that pink frothy sputum, we need to suction that out. We're going to indicate and allowed by state protocol. The CPAP is going to help push that fluid out. Now, if they're altered mental status and cannot maintain their own airway because let's say their oxygen saturations are that low, then we need to provide positive pressure ventilation through a bag valve mask, right? Because the last thing you want is to take that fluid and push it down their airway anymore. Okay. Our goal is to push it out in the interstitial spacing versus causing more issues with the CPAP where they can't protect their own airway at all. So we'll talk more about, like I said, we'll talk more about that in a CPAP specific program, which we have to do together at some point in time. What I actually may have you guys do is actually, as part of a homework assignment, yes, homework, is to actually watch my CPAP video on the YouTube channel that I created, and have you guys do that as an assignment. Therefore, we don't have to go over it again in class. Chronic obstructive pulmonary disease assists with prescribed inhaler. We're going to watch for side effects from overuse of this. We're going to position comfortably and transport properly. So again, COPD, CPAP may be the crush that we need for these patients. If not, give them some oxygen and transport them. Do they actually need that? Be prepared to suction. Assist asthmatic patients with a prescribed inhaler. Determine if it is actually an asthmatic problem. Right? If it's not, and it's an anaphylactic issue, then we need to start thinking about giving epinephrine, which we can do on the lateral thigh, 0.3 milligrams for an adult. We can draw it through the ready check inject system. Provide aggressive airway management, oxygen, and proper transport. A prolonged asthma attack that is unrelieved by many unrelieved into a condition known as status asthmaticus. This is a true emergency. Give patients, give oxygen and promptly transport. All right. People die from status asthmaticus. If it cannot be treated, the airways officially close right up. All right. So we need to get patients that have status asthmaticus and they need to be treated. A lot of times, just getting a paramedic on there that have the ability to do rapid sequence intubation where services do have that ability. Some do. If not, we gotta get to the hospital as soon as possible. Hay fever, unlikely to need emergency treatment. Anaphylaxis, remove the offending agent. Maintain an airway, rapid transport, administer epi. We're not going to give any H blockers, okay, histamine blockers at all. That's Benadryl. So we do not have the ability to do that. It's a level kill. So if you have a patient anaphylaxis, even though it can be treated EMT-wise through epinephrine, get the paramedic rolling, because if they lose their airway, we have an ability to put an intubation tube in place to help facilitate that. One of the other causes of anaphylaxis, or one of the other symptoms, would be angioedema, and you'll start seeing swelling of the tongue, and that can cause a complete airway obstruction. Spontaneous pneumo provides something. Same thing with pleural effusion. Fluid removal must be done at the hospital. They can't do it in the back of an ambulance. These patients just need to get to a hospital sooner than later. Obstruction of an airway, partial obstruction, provides supplemental oxygen and transport. We're going to complete obstruction. We're going to clear the obstruction, administer O2, and transport rapidly to the emergency department. Again, if they're unconscious and they are having a forward body airway obstruction, are done. The difference, you give your breaths, look for the object. If you can see it, take it out. If you can't see it, we do not do blind finger sweeps, right? If they are conscious or unoriented and they are choking, then we can do the abdominal thrusts until they go unresponsive, and then we start CPR. A PE, a pulmonary embolus, supplemental oxygen is mandatory for these patients. Position comfortably. If hemoptysis is present, clear the airway immediately. As you can see, a lot of this stuff here is get them to the hospital. A PE is a surgical intervention to remove. Hyperventilation, complete primary assessment and gather the history. Why are they hyperventilating? What is the purpose behind it? Do not have the patient breathe into a paper bag. Those are old school methods that do not work. Reassure the patient and provide supplemental O2 and transport promptly. environmental, industrial exposure. Before you put them in the back of your ambulance, if they need to be decontaminated, then do so. Decontaminate prior to coming in. If it is a true hazmat situation, we're in the cold zone. We do not go into the warm. We do definitely not go into the hot zone. Let trained professionals that have the right certifications do that. We do not want to take rephrase that. We do not want to take contaminated personnel or contaminated patients in our ambulances. And if we do have a contaminated patient, we need to advise the hospital early enough. So incident command needs to know this so the hospitals can set up their decontents. There's a long process with that. Oxygen and suction base on freezing adjunctation as needed. Foreign body aspiration, clear the airway and provide oxygen. A trach dysfunction, position comfortably, suction to clear the obstruction. A lot of these patients here with trach issues might have what they call a mucus plug. So a lot of times you need to go in there with a suction and remove it, provide oxygen. What we are not doing as EMTs in New Hampshire or Maine is deep suctioning. Suction trach opening only. Asthma, blow by oxygen, MDIs, which is a meter dose inhaler, your albuterol. Cystic fibrosis is a genetic disorder that affects the lungs and digestive system. These patients have a lot of mucus buildup in their lungs. What they may ask you to do is what they call percussion therapy for these patients. If that is the case, with left hand and help break up that mucus. All right, so let's go over some review. We'll take 10 minutes, and then we'll come back with cardiac. So the process in which oxygen and carbon dioxide are exchanged in the lungs is called what? Perfect. A it is. Number 2, which of the following respiratory diseases causes obstruction of the lower airway? Which of the following respiratory diseases causes obstruction in the lower airway? All right. Remember where the lower airway and upper airway break off, okay? All right, so the correct answer is B. Asthma is a lower airway. Croup, laryngitis, not laryngitis, epiglottitis, croup, and they're all upper. Which of the following diseases is potentially drug resistant and is thought to be transferred or transmitted by coughing? Drug resistant and through coughing. You may see this in third world countries as well.
Tuberculosis.
Perfect. Good. Number 4, all the following are causes of acute dyspnea except A, B, C, or D. Correct answer is B, emphysema. That's more of a chronic respiratory disease versus acute. All right. Number 5, bronchospasm is most often associated with bronchospasms.
had asthma.
Well, that's interesting. 5, 6, 7, and 8. Let's go with asthma. I don't know why they had 5, 6, 7, and 8 on there. Interesting. I wonder why people are answering like numbers. Number 6, a sudden onset of difficulty breathing, sharp chest pain, and cyanosis that is persists until consistent with sharp chest pain, cyanosis, difficulty breathing. Also add in syncope. The correct answer is a pulmonary embolus. Remember, sharp chest pain, cyanosis. The key to this is that sharp chest pain is supplemental O2 because you have that blockage in the pulmonary artery. So C. Number 7, albuterol is a beta-2 agonist. Is the generic name for D's. All right. Number 8, an acute bacterial infection that results in swelling of the flap that covers the larynx. All right, epiglottitis. Nice. That's a quick one. A 70-year-old man recently had a heart attack and now complains of severe difficulty breathing, especially while lying flat. His coughing up pink, frothy sputum and secretions is most likely to. I shouldn't have given you the answer to that, but what type of. Remember, pink frothy sputum is a heart failure issue, not a pulmonary embolus. And it's when the left side of your heart starts. All right, so number 10, which of the following patients is breathing adequately? Adequately. All right, perfect. The answer is B. All right, so I'm going to stop here. We'll take 10 minutes, come back at 8:17, and then we'll get started with the next one.
This conference will now be recorded.
All right, so now we're going to cover Chapter 16, cardiovascular emergencies. All right, so pathophysiology, applying the fundamental knowledge of the pathophysiology of respiration and perfusion to a patient assessment and management. So we'll get into the medicine part as well, how to provide basic emergency care and transportation based on the assessment findings for the acutely ill patient, and look at the standard competencies for cardiovascular signs and symptoms and anatomy and management of chest pains and cardiac arrest. We're also going to look at acute coronary syndrome, angina pectoris, and myocardial infarction. We're also going to look at aortic aneurysm and dissections, thromboembolisms, heart failure, hypertensive emergencies as well. So cardiovascular disease has been the leading killer of Americans since 1900 and accounts for 1 of every 3 deaths is some sort of acute coronary syndrome or cardiovascular disease. So EMS can help reduce deaths by encouraging healthy lifestyles, which we can do when we're with patients and things like that. Early access to medical care, more CPR trained of the lay people. So offering the hands-only CPR is a big player in a lot of this. Increased use of evolving technology in dispatch and cardiac arrest response as well. So EMS can help reduce deaths by public access to defibrillation devices. So if you look at, so Taylor, you're still on here, right?
Yeah, I'm here.
Right. So I give props to your chief in Wolfboro because what did he do for the community with that grant that he got?
Yeah, so he got, I can't remember the exact number, but he got all brand new AEDs for most of the public buildings in town.
So I want to say, if I remember talking to Chief Zadi about it, was 50 AEDs for the community and all his apparatus, police cruisers, everything. That was done through the COVID grants that were out there. That's phenomenal. That's public access to defibrillation devices. So if a smaller town like Wolfboro can do it, any town can put stuff in for this kind of stuff. And it helps towards becoming a heart safe community, especially getting AEDs out there. And that's a big designation, especially in Maine. Maine is huge with the heart safe stuff. Vermont was getting very big with it. And then New Hampshire has quite a few communities as well. Massachusetts has like the entire Cape Cod region is all heart safe. Every town on Cape Cod. So they call it Heart Safe Cape Cod because every town got it. And that's heart conscientious communities that are providing free education and cardiovascular education, diabetes awareness, things like that, to communities that are community members at no cost. So again, public access, recognizing the need for advanced life support and the use of cardiac specialty centers when they are available. So we live in a very rural area where we don't have cardiac centers readily available. We have hospitals that can start the process of giving heparin, TNK, Plavix, things like that, but they can't go in and pull a clot out. Those are your PCI centers, and there aren't very many around the areas that we work in. Our closest one to the Ospey Valley is going to be Wentworth Douglas Hospital in Dover. Other than that, it's Portsmouth, Maine Med. There's really not in Dartmouth. I mean, there's really not a lot. CMC, Catholic Medical Center, Concord Hospital have them. When you start getting into the Sanford region, and some people live in Maine, well, look at Dave working in Sockopee. His closest PCI center is Maine Medical Center. What is that, an hour and a half transport, hour transport? So patients having heart attacks. Right, depending on where you're located in the Sockopee region where you're transporting to, it could be an hour and a half. So we don't have that readily available access. You go down to Massachusetts and there's a PCI center on every corner, especially in Eastern Mass, between all the Boston hospitals. Leahy Burlington just became a level 1 trauma center. They have a PCI there. Melrose Wakefield Hospital is a PCI center. The difference is can they pull a clot out, or can they do a coronary artery bypass graft or a cabbage? Those are going to be more of your cardiothoracic surgeons that go in and do those. Portsmouth Hospital, Maine Medical Center, Dartmouth, Catholic Medical Center, Concord, they all have the ability to do cardiothoracic surgery versus just pulling out clots. So again, knowing your centers and specialty cardiac centers when you need to call. You get a STEMI patient, what they call a STEMI, out in like North Sandwich area in New Hampshire. You're calling for a helicopter because the closest one's an hour and 45 minutes away. And that's Concord, an hour and a half. So you're going to be doing air medical transport for STEMIs from the scene. So again, it depends on what you have available to you and recognizing your need for advanced life support. So back to, before we get into this part here, know your resources, know the area that you're covering, and know where you need to go for the right patient outcome. So the anatomy and physiology. The heart's job is to pump blood and supply oxygen-enriched red blood cells to the tissues of the body, right? So remember, we breathe air in, oxygen comes in, attaches to red blood cells go around and around in the body, and they transport oxygen, right? As they drop it off, they pick up carbon dioxide, it comes back around and around, back to the right atrium, right ventricle, to the lungs, the alveoli, and then we have gas exchange. All right, this is divided. The heart is divided down the middle into the left and right sides. each with an upper chamber atrium receiving incoming blood, and a lower chamber ventricle, which is pumping the outgoing blood. And in there is also valves as well. Here's a picture of the hearts. The blood comes in, the oxygenated blood comes in, goes through the right atria, through the aortic valve, through the tricuspid valve, pulmonic valve, through into the lungs where gas exchange happens. Now we have oxygenated blood coming through the left atrium into left ventricle. Left ventricle pushes blood out. This heart cannot pump without a functional electrical system. Those are run by nodes, and they all have intrinsic rates, and we'll talk about those here in a few minutes. All right, so we have one-way valves to keep blood flowing the proper direction. There are 4 different valves in the body: tricuspid, pulmonic, mitral, aortic. Those are going to be our 4 valves that we're going to be dealing with. The aorta is the main artery which receives blood ejected from the left ventricle. So for the firefighters in the room, the aorta is like your supply line. It is like a large diameter hose. Whether you use 4, 5, or 6 inch, I do not care. All right. Either way, it's a big line that takes a lot of water to supply your scene. Your scene is your body. All right. Without having your aorta, it cannot be your supply line. Okay. So think of it that way. Your heart is your fire pump. Your supply line is your aorta. That goes into your 2.5 inch and 3/4 and your garden hoses, everything else you want to fight, whatever fire you want to fight. All right. Without that, your body cannot function. As you can see here, again, slide very small, cannot read it. But what they're saying here is blood comes in deoxygenated, comes round and round, goes through and back out the left ventricle and pushes blood back out to the body. If we have a deviation or an infection, a disease, if we have a blockage, then this can go awry, and this can cause a lot of issues where the heart becomes deoxygenated, causing a heart to become pissed off at you to the point where your start what they call ischemia. So your heart becomes ischemic with lack of oxygen before tissue starts to die. When tissue starts to die, it becomes infarcted. Okay, so infarction. The problem we have here is that we got to prevent this from happening. So we have medications at our disposal to be able to assist with that. Sorry, plane going over. So now we have the heart's electrical system, which controls heart rate and coordinates atria and ventricles to pump. All right, so the heart generates its own electrical impulse starting at the sinus node, what they call the SA node or the sinoatrial node. The impulses then pass from the atria to the ventricles, automatically allow spontaneous contraction without a stimulus from a nerve source. As long as the impulses come from the sinoatrial node, the other myocardial cells will contract when the impulse reaches them. If no impulse arrives, however, the other myocardial cells are capable of creating their own impulses and stimulating a contraction. So let's go to the next slide here. If we have a patient that is electrically functioning appropriately, everything's going to fire from the SA node. Can you guys see me moving the mouse around a little bit?
Yeah.
Yep. All right. Trying to see if I can find the laser pointer, but apparently it doesn't want to work today. Okay. The SA node has an intrinsic rate, which means a firing rate between 60 and 100 beats per minute. Imagine that. That is the normal rate for an adult, 60 to 100. What's happening is it sends the impulses through these lines right here. These are called internodal pathways. It then goes to the AV node, into the AV junction, which is here, and that makes it so that way the impulses don't fire too quickly. It kind of stores energy, okay? Everything fires appropriately. Past the AV junction, you go to the bundle of His. At the bundle of His, it branches off into the right bundle branch and left bundle branch. Electrical conduction comes down through here, goes into what they call the Purkinje fibers, and this is what stimulates the contraction of the ventricle. All right. If for some reason the SA node fails, remember how we talked about failure? The AV node will take over and continue pumping the heart. The difference is that this will fire at an intrinsic rate between 40 and 60 beats per minute. This is your backup generator right here. If this fails, the Purkinje fibers can take over. However, this is your last ditch effort down here, your last generator. And what will happen, your intrinsic rate is between 50 and 30 beats per minute. Or in a book you read, you might say 15 to 40 or 20 to 40. It's a very bradycardic rhythm. So you have backup generators from your AV node to your Purkinje fibers. But if a person is firing normally in a normal sinus rhythm, okay, you'll have a P wave, a QRS, and a T wave, and every one of those waves on an EKG actually means something. All right, so your P wave is your atria depolarizing, your atria firing, pumping blood. Your QRS complex that you're going to see on an EKG, right, is your ventricle depolarizing. So if everybody checks the radial pulse right now, go ahead and check a pulse. Every beat that you feel on your pulse is your ventricle depolarizing. That's your left ventricle pumping. Okay, it's so much electricity that you can't see on an EKG. The atria are repolarizing energy to be able to make the next fire. So it actually repolarizes underneath the ventricular depolarization. The next beat you see is what they call a T wave. That's your ventricle repolarizing or taking back energy to then fire again. So every beat you feel is that QRS complex, and that's your heartbeat. That's where you're going to find your ventricular rate. Does that make sense at all? Okay. Pretty interesting stuff, right? Cardiology is pretty cool. And again, you guys don't learn how to read EKGs until you get into advanced school, but you're still doing 12 leads. You're still seeing it print out, and it's good to have an idea of how it works. And we cover EKGs. We do 12 leads later on. I will actually show you guys on an EKG strip if one of the male students would like to do EKG done, we can show you what it looks like. All right, so a little more of the ANP stuff. The autonomic nervous system, ANS, controls involuntary activities. The ANS has two parts which normally balance one another. We have a sympathetic nervous system, which is a fight or flight, which speeds up the heart rate, increases respiratory rate and depth, dilates blood vessels in the muscles, and constricts blood vessels in the digestive system. In times of stress, this takes control. Okay. Now, there are medications that can stimulate this. We talked about albuterol, right? What they call a sympathomimetic, which will stimulate this. These systems have something called a neurotransmitter that help produce that fight or flight. And the neurotransmitter that produces that fight or flight that gets released in the system is called norepinephrine or epinephrine. Okay. Then the second system is called the parasympathetic nervous system, which slows the heart rate down. Respiratory rates, constricts the blood vessels, all right, and dilates blood vessels in the digestive system. In times of relaxation, this system then takes control. What's happening here is you're having a release of what they call acetylcholine. So acetylcholine then gets released, slowing stuff down. The myocardium must have a continuous supply of oxygen and nutrients to pump blood. Increased oxygen demand during periods of physical exertion is supplied by the dilation or widening of the coronary arteries. Therefore, stroke volume, which describes the volume of blood ejected with each ventricular contraction, increased stroke volume then results in increased cardiac output. So if you're exercising, your body needs more oxygen. To get more oxygen, your heart rate goes up. Makes sense, right? If your body doesn't require more oxygen, then what happens? Your heart rate stays lower. So we start talking about shock in patients. The patient needs oxygen. What happens? The heart rate goes up, respiratory rate goes up, more, so you have faster breathing. The more oxygen is coming in, your body's trying to compensate. So the coronary arteries are blood vessels that supply the blood to the heart muscles, which start from the first part of the aorta, just above the aortic valve. The right coronary artery supplies blood vessels to the right atrium and right ventricle, and in most people, the inferior wall of the left ventricle. The left coronary artery supplies blood to the left atrium and left ventricle and divides into two major branches just a short distance from the aorta. So literally, once you become an ALS provider, you can look at an EKG, see where the infarct is, and have an idea of what vessel is being occluded by looking at a bunch of squiggly lines and where they're located on a 12-lead EKG. So this figure illustrates, the side illustrates how the coronary arteries carry the blood supply to the heart. All right. So arteries, the arteries supply oxygenated blood to different parts of the body. So the right and left carotid arteries supply the head and the brain. The right and left subclavian arteries supply the upper extremities. The brachial artery supplies the arms. The radial and ulnar arteries supply the lower arms and hands. The right and the left iliac arteries supply the groin, pelvis, and legs. The right and left femoral arteries supply the legs. And the anterior and posterior tibial and peroneal arteries supply the lower legs and the feet. All right, so knowing where these arteries are located can also help you find pulses. Some of the things you're going to look for, obviously the back of the leg would be a popliteal. You have your tibial pulse, you have a dorsipedal pulse on the feet, tibial pulse on the ankle. You have brachial pulses, brachial artery. Underneath the bicep, you have radial pulses underneath the radial bone. Corner, you also have carotid pulses in the carotid arteries. So there's different places you can check pulses, also where your arteries are also located. The arterioles and capillaries are smaller vessels that receive blood from the arteries. So capillaries are one cell thick, exchange nutrients and oxygen for waste at the cellular level. All right, so that's why we check capillary refill to make sure that we're being perfused appropriately. So if we push on our skin, our nail beds, we should have a cap refill of 2 seconds. Anything greater than 4 seconds, we have low perfusion, right? We try to look at between like 2 to 3 second refill. Anything greater than 4, though, is bad, okay? It means we're not getting enough perfusion to the extremities. This connects arterioles to venules, and the venules are veins, and veins receive blood from the capillaries that are deoxygenated. Venules are the smallest branches of the veins. The vena cava then returns oxygen-poor blood back to the heart through the superior, which is upper, which carries from the head and the arms, and the inferior is lower vena cava. So superior and inferior vena cava, the inferior or lower side brings it back from the lower extremities, from the abdomen, kidneys, and the legs back to the atrium. So our cellular exchange at the capillary level is bringing back the deoxygenated blood. So blood consists of several types of cells and fluid, okay? So if you ever hear of somebody, if you've ever been into a lab and they say, we want to order a lab panel, and they say a CBC, which is a complete blood count, this is what they're actually ordering. They're going to look for red blood cells, white blood cells, and they're going to look at platelets, plasma counts, also hematocrit and hemoglobin as well. This will tell if someone has any kind of internal bleeding. So blood consists of the 4 types: red blood cells, which carry oxygen and remove carbon dioxide; white blood cells, which fight infection; platelets, which help blood to clot; and plasma, which is in the fluid that cells float in. And this can all be done with a blood draw and through lab tests and everything else, but this is what we need to know about it. So what patient would you see having trying to how to word this. What patient would you come in contact with that would have 0 white blood cells? Okay. What else?
Is the other one HIV?
Yep. And cancer. Patients receiving chemo will knock out their white blood cell count. Therefore, they can no longer fight infection and become very susceptible to becoming very sick. So if you go to a patient's house, and they say that they have cancer and that they're receiving doses of chemo, one of the things you want to make sure you pay attention to is make sure you're protected. Or I'm sorry, rephrase that you're protecting them. So even if masks weren't a thing, put a mask on. Right? These people can have them wear one as well. They cannot get sick. Okay. Now, what type of patient would you see a high white blood cell count in? What would you see a high white blood cell count? Someone with an infection, yeah. So like pneumonia, things like that, you might see a higher white blood cell count. Any kind of inflammation, yep. And we'll stick with that, Emily, is inflammation, but there's other ways to check inflammation as well, doing different types of panels, but we'll keep it simple. Yeah, inflammation, any kind of infection like that. All right. So, blood pressure is the force of circulating blood against an artery wall. Systolic blood pressure is the maximum pressure generated in the arms and legs during its contraction of the left ventricle during a period known as systole. The top number in a blood pressure reading. The diastolic blood pressure is the pressure against the artery walls when the ventricle relaxes, which is the bottom number. If you have a very high bottom number diastolic pressure, we start seeing patients that are very hypertensive. It's going to become a hypertensive crisis and can cause someone to have a stroke, heart attacks, things like that, which is why we got to really educate people that our normal blood pressure should be around 110/70. Right? We start seeing patients with blood pressures of 130 or higher by terms. That's what they call pre-hypertension. We're getting into that point where the patients are becoming very hypertensive eventually. So you got to start working on like diet control and things like that. They try to do diet and eating healthier before they start getting patients pumped full of medications. Medications can be detrimental because, especially for us as providers, because you have patients that are put on like ACE inhibitors, like lisinopril, or they're put on beta blockers like metoprolol. Beta blockers decrease heart rate. So if they're on a high dose beta blocker and let's say they're bleeding internally, you might not pick up on the signs of shock with that because of the fact that they're on a beta blocker and it keeps their heart rate down, which will actually mask the signs of tachycardia, right? Normally, low blood pressure is perfectly fine as long as it's not too low. But some people live with a low blood pressure, and that's not a bad thing. The question is, Deb, to kind of answer that as well, are they symptomatic? Like if they stand up and they keep passing out, they may have to get put on a medication to help increase their pressures. And that's perfectly fine because your mean arterial pressure for that is still above 65, which means your body is still perfusing perfectly fine with that. So a pulse felt with a blood pressure passes through an artery during systole. This is more of your peripheral pulses. This is what they call a bipalp. So peripheral pulses felt in extremities, central pulses felt near the body's trunk. This is more of a rule of thumb deal. Okay, this is more PHTLS, quick down and dirty stuff. If you have a radial pulse on a quick assessment, your blood pressure should be 90 or higher, roughly. Okay, this is not exact. If you don't have a radial pulse and you have a carotid pulse, your blood pressure is systolic, usually right around 60. Those are quick numbers, or for trauma life support stuff, where you don't have a blood pressure cuff readily available for you. But it's a good thing to kind of keep in the back of your head. If you have a radial pulse, your blood pressure, if it's strong radial, the blood pressure is usually right around 90 systolic. So in this slide here, it kind of tells you where to look for different pulses. You have femoral, brachial, carotid, radial, posterior, tibial, and dorsal pedis pulses. All right, so cardiac output. Cardiac output is defined as the volume of blood that passes through the heart in 1 minute. This is calculated by multiplying the heart rate by the volume of blood ejected each contraction, which they call stroke volume. So in the field, stroke volume can be roughly determined by the heart rate and the strength of a patient's pulse. Perfusion describes the constant flow of oxygenated blood to the tissues. So good perfusion requires the following: a well-functioning heart, appropriate heart rate which allows proper volume of blood to be circulated, an adequate volume of fluid or blood. Reduced volume through hemorrhage limits the amount of tissue that can be perfused. That's when we start going into shock, an adequate state of tissue perfusion. Blood vessels must be appropriately constricted to match the volume of blood available. Dilated blood vessels mean reduced perfusion. If perfusion fails, cellular death occurs and eventually the patient will die. So we talk about blood vessels must be appropriately constricted to match. Right? Septic patients can have widespread vasodilation with bacteremia or bacteria in the blood. Therefore, dropping their blood pressures down to an unmanageable state where they actually need to be put on medication called a pressor to bring it back up again. Which is why we treat septic patients with a lot of fluid, because they become dehydrated, they become widespread vasodilation. These patients need to be treated quickly. That's why it's so important to pick up sepsis in the field and call in your sepsis alerts at the hospital. So it's more than just a cardiac issue. Other infections can cause widespread vasodilation as well. There we go. So chest pain usually stems from ischemia, which is a decreased blood flow. They start developing chest pain. They say, oh, my chest is starting to bother me, right? That's when we start talking about angina, ischemic patients. So ischemic heart disease involves a decreased blood flow to one or more portions of the heart. If blood flow is not restored, that tissue dies. Remember, there are 3 types of muscles in the body, right? What are they? What are the 3 types of muscles in the body? So I see smooth, skeletal, and one more. So we have skeletal muscle, smooth muscle, and then what are we talking about now? Cardiac, right? We have skeletal muscle, smooth muscle, cardiac muscle. Skeletal muscle can be rejuvenated, right? If it's ischemic, we get blood flow back to it, right? Smooth muscle, the same thing. When cardiac muscle dies, it cannot be rejuvenated, okay? Keep that in mind. Patients are having chest pain. They always say time is muscle. The longer they're without oxygen, the higher chance muscle is going to die and it cannot come back. Right? So atherosclerosis is a disorder in which calcium and cholesterol build up and form a plaque inside the walls of the blood vessel, as you can see in the picture over here. Okay, so this is normal, and we start getting plaque buildup. All right, that's all your French fries and cheeseburgers and all the other crap that people eat that tastes so good, yet builds up all this plaque inside it. So this can cause a complete occlusion or a blockage of a coronary artery and other arteries of the body. So fatty material then accumulates as a person ages, resulting in the narrowing of the lumen, which is the inside diameter of the artery. The inner wall of the artery then becomes rough and brittle. If a brittle plaque develops a crack for unknown reasons, the ragged edge of the crack activates the blood clotting system, resulting in a blood clot that will partially or completely block the lumen of the artery. If lumens become blocked, we start developing chest pain. Therefore, it can no longer deliver oxygen to that area of the heart, therefore causing pain, ischemia, and then potentially infarction if it's not treated quickly. This is where they go in and they perform in a PCI center and perform a stent. They go in and they put a stent in place. What they call a cardiac catheterization. A thromboembolism is a blood clot floating through the blood vessels. If it reaches an area too narrow for it to pass or stops or blocks blood flow at that point, tissues downstream from the blood clot will suffer from hypoxia. If too much time passes before blood flow is resumed, the tissue will die. We talked about that already, though, right? The tissue dies, we can't rejuvenate it. The sequence of events is known as an acute myocardial infarction, called an AMI, or a classic heart attack. Infarction means the death of the tissue. The death of the heart muscle can severely diminish heart's ability to pump, called cardiac arrest. So the patient will go into cardiac arrest if we can't restore blood flow. All right. So if people are having chest pain, please do not walk them down the stairs. Please do not walk them out to the ambulance. I don't care if they're 19 years old. I've been to 19-year-old STEMIs before, right? It can happen, family history. Okay. So please do not walk these patients. Put them in a stair chair. Do not make them exert themselves. Do not sign them off, please, for the love of God. Do not sign off chest pain patients, right? Contact medical control. Have the doctor talk with the patient to convince them to go. If all else fails and they're alert and oriented, they have that right to sign off and refuse transport. But do the best you can as a patient advocate to get them to go. That means, even if that means involving a doctor to talk with on the phone. So in the United States, coronary disease is the #1 cause of death for men and women. The peak incidence of heart disease is between 45 and 65 years old, but can strike individuals ranging from their teens to their 90s. It can happen any time. Risk factors a person placed at a higher risk of an AMI are cigarette smoking, high blood pressure, elevated cholesterol level, elevated blood glucose level for diabetes, lack of exercise, obesity, some major uncontrollable risk factors, older age, family history, race, ethnicity, and then the male sex. Acute coronary syndrome, ACS, describes a group of symptoms caused by myocardial ischemia. This includes temporary myocardial ischemia resulting in angina pectoris, or a more serious condition called an acute MI. Right? So patients are developing chest pain, but can it be relieved with rest? Or do they start needing nitrates to help vasodilate? Right? We start talking about stable and unstable angina. Angina pectoris occurs when the heart's need for oxygen exceeds the available supply, which usually during physical or emotional stress. It can result from a spasm of an artery, but is most often a symptom of plaque buildup. This may be triggered by a large meal or sudden fear. This is why we shouldn't be overeating. When increased oxygen demand goes away, the pain typically goes away. Angina pain or angina pain is commonly described as a crushing, squeezing, or something, or someone is standing on my chest, that pressure, usually felt in the mid portion of the chest under the sternum. This can radiate to the jaw, arms, frequently to the left arm, mid back, and epigastrium, the upper middle region of the abdomen. Usually lasts between 3 to 8 minutes, but rarely longer than 15, and then it goes away. This is your angina pectoris. May be associated with shortness of breath, nausea, or sweating. Usually disappears promptly with rest, supplemental oxygen, or nitroglycerin. Although angina does not usually lead to death or permanent heart damage, it is a warning sign that should be taken seriously. Maybe it's time to change your diet, change your lifestyle. Another thing they can also do as well, they can do what they call they can have you scheduled for a catheterization, and they go in and do what they call a diagnostic cath. They go in and say, oh, look, he's got a blockage. Or they'll do a stress test to find out if you start developing these chest pains and things like that. And then they'll send you in for a scheduled catheterization to kind of put a stent in place before it actually gets worse than what it actually is. Unstable angina is a response to fewer stimuli than normal. So stable angina responds to rested nitro. But patients experiencing chest pain or discomfort should always be treated as they are having an acute MI. Again, you can have a patient that is having an active heart attack, okay, that does not have changes in EKG. So Deb, to answer your question, yes, it's compromised, depending on how bad the infarction actually is. So what they're going to do is they're going to go into a cardiac catheterization. So your next ride time, if you do one with me at all, I actually have pictures on my phone for I did a case study on a cardiac patient that I had. I actually wrote an entire case study on it, where the patient actually went into cardiac arrest. We got the patient back. We transferred him to a PCI center. I sat there and they let me take pictures of before and after when they put a stent in. And their patient is still compromised, so there's still a stent in place, and they may be on blood thinners. They'll be on Plavix for a while. Then they may be on blood thinners for life, depending on the type of stent they placed. But remind me, and I'll show you guys the case study. Yeah, that's fine with me. I'm always there Monday and Tuesday. I just gotta remember to bring the right computer that has the case study on it. So back to what I was saying though in the previous slide here. You can have something called an NSTEMI, which is a non-ST elevation MI, where the patient has bumped cardiac markers, which means they're actually actively having a heart attack without having the EKG changes. So they call an NSTEMI, non-ST elevation myocardial infarction. And the cardiac markers they look for, one of the biggest ones is called troponin. And they'll see those troponin levels being increased, greater than 0.02. They look for 0.04 and higher. They usually start saying there's some kind of injury, damage of some sort. So acute MI signals acute death of cells in the heart muscle. Remember I mentioned before, time is muscle. So once dead, the cells cannot be revived. So they do give medications if the patient's having a potential heart attack or say a STEMI. So they'll give clot busting thrombolytic drugs or angioplasty within the first few hours, prevent damage, and immediate transport is essential. So with that being said, some of the medications they're going to administer would be like they'll do a heparin bolus followed by a heparin drip based on patient's weight. They're also going to give 300 of Plavix and 50 of what they call T and K. So there's different medications they're going to be administering, along with depending on where the STEMI is located, they're also going to receive nitrates as well, depending on where it's, like I said, where it's located in the heart. So they will, so once the cell dies, remember I mentioned before, it cannot be revived. So they will turn into scar tissue and become a burden to the beating heart. About 30 minutes after blood flow is cut off, some heart muscle begins to die. After about 2 hours, as many as half of the cells in the area may become dead, may be dead. After 4 to 6 hours, more than 90% of the cells will be dead. Opening the coronary artery with either a clot-busting thrombolytic drug or angioplasty, which is the mechanical clearing of an artery, can prevent permanent damage if it is done within the first few hours after the onset of symptoms. So onset of symptoms, immediate transport is essential for these patients. That's why it's always important to ask them, how long has this chest pain been going on for? And usually the key marker is 90 minutes we look for. And 90 minutes from the time the symptoms started to the time a balloon is placed and the PCI is being done. That's not getting them to a hospital, it's getting them to a PCI center. All right, that's what's very important. It's not just getting them to any regular ER. It's getting them to a PCI center where they're going in and removing the clot or placing a stent. So some of the signs of an acute MI are weakness, nausea, sweating, chest pain, discomfort, or pressure, lower jaw, arm, back pain, abdomen pain, neck pain, irregular heartbeat or syncope, fainting, shortness of breath, nausea, vomiting, pink frothy sputum, and sudden death. An acute MI pain differs from angina pain, so not always due to exertion. This may occur at any time. Sometimes when the person is sitting down quietly or even sleeping. If it does not resolve in a few minutes rather than last between 30 minutes or several hours, it may or may not be relieved with rest or nitroglycerin. A lot of times you'll be called to a patient's home and they're going to say, oh, they've taken like 6 nitro with no relief. That's a lot of nitro, by the way. Not all patients are having acute MI experiences pain and recognize when it occurs. Females present differently than males at times too. Females may just have shoulder pain, mid-back pain, or upper between the shoulder blade pain. That's it. Diabetics with neuropathy may only develop a upper epigastric pain, and that's all they're going to have. They could be having a heart attack. So again, look at the sex of the patient, look at their medical history, everything. When called to the scene of a chief complaint is chest pain, complete a thorough assessment no matter what the patient says. Do a thorough assessment. Acute MI and cardiac compromise physical findings: fear, nausea, poor circulation, fast, irregular, or bradycardic pulse, decreased normal elevated blood pressure, normal or rapid or labored respirations, the patient experiencing feelings of impending doom. I'm going to die. There are 3 serious consequences of an MI. One being a sudden death resulting from cardiac arrest, cardiogenic shock, or congestive heart failure. These are 3 different serious consequences that can happen with the pathophysiology behind it. They can also have a dysrhythmia, which is a heart rhythm abnormality, like PVCs, premature ventricular contractions, tachy or bradycardia, ventricular tachycardia, or ventricular fibrillation. All these here can have a pulse, will have pulses. VTAC can have a pulse, or they could be pulseless VTAC. And VFib does not have a pulse. These are your shockable rhythms that the AED will pick up. A patient in VFib, remember, described as a disorganized, ineffective quivering of the ventricles. At this point in time, there is no blood being pumped through the body. The patient usually becomes unconscious within seconds. Defibrillation may also convert this arrhythmia, so getting that defibrillator on can be very helpful at that time. Defibrillation restores cardiac rhythms. It can save lives. Initiate CPR until the defibrillator is available. Asystole is the absence of all heart electrical activity. It reflects as a long period of ischemia. Nearly all patients will die from this. Cardiogenic shock, often caused by a heart attack, where the heart lacks the power to force enough blood through a circulatory system. Patients in cardiogenic shock may require pressors to get the heart pumping effectively again. Inadequate blood tissue, inadequate oxygen to body tissue causes organs to malfunction. With that, often caused by a heart attack, and the heart lacks the power to pump. These patients need assistance, and something we're going to be able to do at the EMT level. These ones require paramedic care quickly. Recognize shock in early stages, because remember, they're going to have decreased blood pressure as well. Congestive heart failure, we did that a lot in respiratory already, which occurs only a few days following a heart attack. So again, they may start developing some fluid. So CHF develops with increased heart rate and enlargement of the left ventricle, no longer make up for the decreased heart function due to diseased heart valves or chronic hypertension. That is called congestive because the lungs become congested with fluid, pulmonary edema, once the heart fails to pump effectively. So we have left-sided heart failure and our ventricle is not pumping effectively. Our right side is still functioning appropriately, pumping more blood in, but the left ventricle can't pump enough out and meet the demand. Therefore, it backs up into the lungs. This can occur suddenly, which can be very quickly to the point where they start drowning internally like that, or it can develop over months. The acute onset of CHF or severe pulmonary edema is accompanied by pink frothy sputum and severe dyspnea. Fluid may also collect in the other parts of the body, like what they call dependent edema, such as in the feet and legs. Hypertensive emergencies involve any systolic blood pressure greater than 180 or a rapid increase in systolic pressure. So sudden severe headache is a common sign of this. Other symptoms include the following: strong bounding pulses and ringing in the ears as well. These patients need to be transported to the hospital immediately for a hypertensive crisis, because that can cause a significant stroke or a heart attack. Other common signs and symptoms would be nausea, vomiting, dizziness, warm skin, nosebleeds, altered mental status, and sudden development of pulmonary edema. So if you respond to someone with a nosebleed, don't just play it off as a nosebleed. Check their blood pressure. There very well could be very hypertensive causing that. And I've caught that quite a few times with patients that have had constant nosebleeds. I thought they were just, oh, it's just my nosebleeds all the time. Well, it's because your blood pressure is 220 over 110. Probably should get that looked at. If untreated, it can lead to a stroke or a dissecting aortic aneurysm. That's very bad if your aortic aneurysm dissects. You can bleed out very, very quickly. Keep in mind that your aorta is the same size as a quarter, roughly, going straight down. So imagine that having your major blood supply, you can bleed out within 90 seconds. Consider transporting patients quickly and safely. If you suspect a dissecting aortic aneurysm or an aortic aneurysm in place, you feel like if you're palpating around the umbilical and you feel like a pulsating mass that's there, it could be a AAA, abdominal aortic aneurysm of some sort. If that is the case, you want to transport rapidly, but you also want to minimize the amount of bumps that you hit because that can actually cause that to rupture. So remember, an aortic aneurysm is a weakness in the wall of the aorta. It's susceptible to rupture. So if ruptures, blood vessels will cause patient die almost immediately. Like literally, they will die immediately. If the patient has an aortic aneurysm that ruptures even on an OR table, they have like a 2% chance of survival. Dissecting aneurysms also occur when the inner layers of the aorta become separated, allowing blood to flow at high pressure between the layers. Uncontrolled hypertension is the primary cause of this. So you got to make sure that you're recognizing this and treating it. Nick, did I answer your question? Sorry, I had to push the chat box aside for a minute. All right, perfect. All right. So as you can see, looking at the AMI versus ascending aortic aneurysm table here versus onset, quality, severity, time, region, some clinical signs between the two as well. All right. So some signs and symptoms of an aortic aneurysm. Very sudden chest pain, which comes on full force. Different blood pressures as well. So check a blood pressure from right to left and transport patients quickly and safely. These patients need to be at an OR quickly. All right, so let's talk about assessments here. And after we finish this presentation, I want to show you guys one thing before you go on how to find that CPAP class really quick, all right? So we're going to ensure the scene is safe, standard precautions, looking at the nature of illness, looking at clues from dispatch, the scene, the patient, and family members and bystanders. Form a general impression. If unresponsive and not breathing, begin CPR, call for an AED. Anytime you go to a patient, you should have a minimum of your cardiac monitor or AED when you go inside anyways. If you're running an EMT only truck, AED first in bag. Bring it in with you. Oxygen as well. Over there, the last thing you want to do is have a patient go into cardiac arrest and you go, oh crap, I left it in the truck. If you're going for a chest pain, bring it in with you. All right, so different than being a paramedic or an AEMT. Bring your cardiac monitor inside with you. Airway breathing. Oxygen saturation less than 95%. Give them oxygen. With a normal breather, 15 liters per minute. If not breathing adequate, not breathing or inadequate breathing, 100% oxygen via BVM. Pulmonary edema, CPAP or BVM. All right, assess the patient's airway and breathing. If dizziness or fainting has occurred due to cardiac compromise, consider the possibility of a spinal injury, okay? Got to be careful. Just because they're there for cardiac and they collapse doesn't mean they didn't cause traumatic injury to their spine. Assess the patient's circulation, pulse, rate, rhythm, and quality, skin color, moisture, temperature, cap refill time. Consider treatment for cardiogenic shock early to reduce the workload of the heart. So you want to position the patient in a comfortable position, usually sitting up and well supported. Make a transport decision based on whether you are able to stabilize life threats during the primary assessment. The remainder of the assessment can be performed en route if time allows. Most patients with chest pains should be transported immediately. Please do not sit around seeing and wait. Now, New Hampshire and Maine, this is in addition to National Registry. Right? If you have the ability to do a 12 lead, get a 12 lead within the first 10 minutes of patient contact. Before you start doing any treatment, oxygen is perfectly fine. But before you give nitrates or anything else like nitroglycerin, get a 12 lead. All right? Pre and post treatment. Follow local protocols, determine receiving facility is most appropriate. If you're at the basic level, EMT level, they're not going to tell you to bypass. You're going to want a paramedic on board to do that. Nearest facility or medical center with special capabilities. So again, local protocols, follow them. Determine whether to use licensed sirens for each patient, partially based on estimated transport time. Remember that licensed sirens can also increase anxiety levels. And the last thing you want to do is put more stress on that patient. As a general rule, patients with cardiac problems should be transported in the most gentle, stress-relieving manner possible. History taking, we look at our sample and OPQRST. Make sure we get all of those as well. Again, no difference from what we've talked about already. Onset, provocation, quality, radiation, severity, and time. Allergies, medications, pertinent medical history, last oral intake, events leading to illness or injury, and what happened. How long have you had the chest pain for? What were you doing when the chest pain came on? Were you sitting? Were you lying down? Were you sleeping? Were you outside exercising, working, mowing the lawn? Get that information. Find out what they were doing prior to it happening. What triggered this response? Looking at the OPQRST again, where did the problem begin? What makes it better or worse? Does sitting and resting make the pain go away? What's the quality feel like? Is it a sharp? Is it a dull pressure? Dull, sharp pain, pressure, stabbing? Does it radiate anywhere? Does it radiate the arm, the neck, the back, the jaw? You're going to ask these questions. On a scale of 0 to 10, 0 being no pain, 10 being the worst pain imaginable, where would that pain be? And then how long has it been going on for? Has it been going on for 10 minutes, 20 minutes, an hour? I've had patients that told me I've had chest pain for the last 2 weeks. Like, what made it worse today that you decided to call, versus 2 weeks ago when it first started? Ask those questions. You want to find out why. Obtain vital signs. Measure and record the patient's vitals. If available, use pulse oximetry if you have it. You want to assess circulation, respiration, skin color, and temperature and condition. If you walk into a patient and you see them pale, cool, clammy, and diaphoretic, we know that there's shock-like symptoms. They're not being perfused. Why are they not being perfused? We're going to reassess vitals every 5 minutes or when the patient's condition changes significantly. Sudden cardiac arrest is always a risk. So if cardiac arrest occurs, perform CPR immediately until an AED is available. Reassess your interventions. Anything you do, reassess it. If you have nitro, reassess it afterwards. Did the blood pressure drop? Did it go up? Do another 12 lead. Okay. You might have made the patient a little bit better by vasodilating, and we're not going to be able to see the initial EKG. That's why you do pre and post. Communication, documentation. So as far as emergency care goes, we're going to ensure proper position, give oxygen as needed, depending on protocol, prepare to administer low-dose aspirin, right, and assist with prescribed nitroglycerin. Maine and New Hampshire, you guys have the permission through standing order to give aspirin. Up to 324 milligrams, or aspirin comes in 81 milligram tablets, so that's 4 tablets, and they're chewable. The nitro has to be prescribed by the patient. You cannot pull it out of the drug box. Use a nasal cannula for patients with mild dyspnea. If they have mild shortness of breath, you don't need to put a full monitor breather on. Just give them a nasal cannula, set it at 4 liters a minute, and see how they do. Use non-breathing face masks for patients with more serious respiratory difficulty. Titrate the oxygen to obtain an oxygen saturation between 95 and 99%. We don't want to go higher than 99%. 100%, back in the day it was good. Now they're saying we don't want to make it 100% anymore. We want to keep it down below 100, or that we're not over-oxygenating the patient. If they're unconscious, we're going to assist the patient with breathing as well as those obvious respiratory distress. We use a BVM or positive pressure ventilation device according to local protocol. So we have BVMs. So aspirin effects prevents blood clots from forming or getting bigger. Aspirin is not a blood thinner. It's a platelet aggregator. It makes platelets less sticky to prevent any further clotting. They come in 81 milligram chewable tablets, and the recommended dose is 162 to 324 milligrams. Follow your protocol. Nitroglycerin available forms are a sublingual pill, sublingual spray, or a skin patch applied to the chest. Okay, patients are usually going to have the nice sublingual pill, a lot cheaper. The spray bottles go for about $300 a pop, so patients aren't going to pay for those. They're going to get the bottles that go for like 50 cents. They're not much, right? So that's what they're going to end up having is tablets. When we're administering these, they have to be administered under the tongue, which is called sublingual, right? Make sure they do not chew or swallow, and make sure they understand that this can also cause a headache to the patient as well, right? Especially if they've never had it before. The mechanism of action for nitroglycerin is that relaxes blood vessel walls, causing vasodilation. It also decreases workload of the heart, increases blood flow and oxygen supply to the heart as well. This will help, hopefully, in turn, reduce that chest pain. Yes, because we're in, Dave, because we're in a training situation, we can discuss it as long as addresses and names aren't put out there.
Okay, because you're hitting kind of stuff where that may or may not have been done there, just on because the situation was fluid. But you keep hitting it. It might be a good example for the class who are outside of EMS. It might be a learning experience.
Do you want to bring up a call that you went on with that?
No, it wasn't my call. It's a family situation. So,
If
but
it's a family situation, it's totally up to you if you want to talk about it.
yeah,
As long as you don't bring up any, like you said, names or things like that, addresses, and it's used in a training situation, we're not bound to HIPAA for that, as long as it's used in training situations only.
okay.
Did you want to bring something up, or are you good?
Well, I wasn't sure if I wanted to do it now or maybe towards the end because it has to do with it's just like, I don't know if you want to do it now and interrupt the class, but you keep touching base on certain things that just keep resonating in my mind that that situation didn't happen.
Yeah, if you want to bring it up now, that's fine with me.
Okay. So with just not to extend our class, but we were talking about like patient advocacy in most of our classes and stuff like that, or primary assessments, general impressions and stuff like that. So the situation that we're going through is a female was found unconscious. 911 was called. From the pictures, because you're talking about taking gear in, I didn't see any first in bags. I didn't see any cardiac monitors. I didn't see anything that we would normally take in with EMS for an unconscious female. How long she's been down, who knows. The only thing I saw in one person's hand, other than their pads, because they're doing, what we do on our pads when we're doing there, but glucose was held. I do know that glucose was checked. Person was at 20 for their glucose reading. They were brought to conscious. Glucose was administered. No transport. No patient assessment, and they were gone. Next morning, 911 was called because she wasn't feeling well again. Transported to hospital at that point. Turns out, because nobody checked her, she had a broken rib, collapsed lung, and an infection. So it just resonates the fact that we should be a patient advocate when we're in EMS and not to overlook stuff, because you kept kind of touching base on things like that and making sure that we're encouraging them to go, regardless if they felt fine because of glucose and stuff like that. In this situation, it could be anything with chest pains and stuff like that. So, and so anyways, that day, she was at one hospital, airlifted to another. Within hours, she was sedated, intubated, and in liver and kidney failure. And she is in that position to this day. All because maybe one day earlier, it could have been handled easier, differently. So I just wanted to stress like patient advocacy out there for all of us who are either in EMS or going into EMS or plan on making a career of this stuff. So, and patient assessments, totally something we should be doing with every patient. Like you said, if it's a simple nosebleed, we're not going to walk away. If it's a simple nosebleed, we're going to investigate, become detectives and stuff like that. It's just some stuff that I saw failed in this situation that we're learning here. And I just thought, hey, maybe I should bring this up as an example outside of the book.
It kind of goes with what I was talking about before with that 19-year-old that had the PE that they blew off, and if I hadn't been in that room, she'd be dead today. Because I refused to leave her side, and then she coded twice. Imagine if she had no cardiac monitoring, no monitoring in general. So if she had coded, who would have known she was in cardiac arrest until they came back in the room a half an hour later? That's what nurses do. They go in, They do evaluation, they don't come back for a while, and then she would have been dead. There would have been no chance of survival with that.
Yeah.
So yeah,
Just, they
thanks for
didn't.
bringing it up. It's there, and people that have worked with me, I'm the biggest pain in the butt you can find when it comes to getting a patient to go to the hospital. I hate doing refusals because it's more of a liability to sign someone off than it is to transport.
Yeah, because this particular department, and I know my family friend is definitely going to be going, why was she not taken that evening? You know.
Right.
So
So
and there was like 4, 5, 6 guys standing in this room. So
Right.
it's like nobody said, hey, maybe we should do a full body. We don't know how she fell, where she fell. I mean, she was in her room, but still, it's still a fall. And as we all know from this, as we get older, we get frailer. So, but
I know we don't bring a ton of war stories, but I'll bring something up that happened just recently with a call that I went on, and kind of again goes again the patient advocacy. We had called for a simple alpha level fall. Patient was found sitting on the ground with some lumbar pain, thoracic lumbar pain only. We get her in the back of you get this patient in the back of the ambulance, and we start transporting. We give pain management, to help with the pain and all that. Next thing you know, it goes into a full-blown seizure, it's anaphylactic reaction to something. We end up RSIing her and intubating her. Patient gets transferred to another hospital, and they found that she had a toxic encephalopathy and polypharm toxicity. So, very interesting, rare case. But again, if we hadn't have taken her, what would have happened at home? And I was very persistent on getting this patient to go to the hospital. They kept on saying no, no, no. If I had walked away, they would have gone into a full-blown seizure and went unconscious. And it happened in front of us versus happening at home when no one was around. So again, patient advocacy is huge to get the patients to go to the hospital.
yeah,
So
and I will give kudos to one of your team members at Action, because we went on a call, and even though that the wife said otherwise for the fall that she assisted, your team member still had me do a body palpation of the neck, the back, and all that other stuff.
Yep.
Even though she assisted him, and he insisted on it.
So patient advocacy, do your patient assessments, because you might miss something if you don't. All right, so back to nitroglycerin. Thanks, Dave, for the story, by the way. It was very helpful. So side effects, severe headache, change in pulse rates as well. Some contraindications, obviously, with nitroglycerin would be systolic blood pressure of less than 100, head injury, the use of erectile dysfunction medications or drugs within 24 hours, and then maximum prescribed dose has already been taken. Usually 3 doses is usually a max dose. We don't want to give any more than that unless you're at a higher level where you can get IVs established and giving fluids behind it. So administering nitro, ensure the medication is not expired nor contaminated. Ensure medication is prescribed to that patient, and make sure you wear gloves, because the last thing you want is to get that nitro on your hands, because that can also be done through your skin as well, transdermal, and it can also decrease your blood pressure as well. And the last thing you want to do is give a patient a medication and you pass out in the back of the ambulance, right? So we don't want that to happen. Cardiac monitoring, which is something that is going to be allowed for the EMT level in Maine and New Hampshire. For an EKG to be reliable and useful, electrodes must be placed in consistent positions. We are going to go over this stuff here in depth on one of our practical days. Principles of the basic principles should be followed to minimize artifact in the signal. Artifact is ECG tracings and a result of interference. It's hard to see. So some guiding principles may need to shave body hair. So if they have a lot of body hair, you need to shave it off. Rub the electrode site with alcohol swab before application. And then you're going to attach the electrodes and ECG cables before placement. Then we're going to confirm electrode placement by looking at the pictures as you can see here. So you do like I said, we're going to go over more of this in depth on our practical day because I have to certify you guys in 12 leads in both states. So white and black on top, green and red on the bottom. So the way to remember this is white to the right, smoke over fire. So obviously red being fire, black being smoke. And then green is always, grass is always underneath the clouds, so green on the right-hand side. And then we do our vector leads, which is V1 through V6. Remember this here is V1 and V2 are the fourth intercostal space, counting down the ribs, fourth intercostal space right and left of the sternum. Then we're going to do V4 next, which will be your mid clavicular line, follow the clavicle down underneath the fifth intercostal space. V6 will be fifth intercostal space, mid axillary line, so through the axillary. And then you put 3 between 2 and 4, and 5 between 4 and 6. Good way to remember it. Again, it's going to be all pretty much hands-on stuff. Again, I have to certify you guys this anyways for both states. Once the electrodes are in place, we're going to turn on the monitor. We're going to print a sample rhythm strip. As the strip shows artifacts, confirming electrodes are firmly placed and plugged in. Cables are plugged in appropriately. All right, so back to heart surgeries and cardiac assist devices. Many open heart operations have been performed in the last 30 years. So coronary artery bypass graft, or they call it CABG, C-A-B-G, where the chest or leg blood vessel is sewn from the aorta to a coronary artery beyond the point of obstruction. A percutaneous translumal coronary angioplasty is a tiny balloon which is inflated inside a narrowed coronary artery. Patients who have had a bypass procedure may or may not have a long scar in the chest, right? So treat chest pain in a patient who has had any of these procedures the same way you would treat a chest pain in the patient who is not. For some people may also have cardiac pacemakers. So you want to look in that chest, and they can be placed in the right or left-hand side, all right? And you want to ask them, do you have a pacemaker in place? Is your pacemaker also a defibrillator? Ask them if it has both. Okay, when you're doing your assessment. Cardiac pacemakers maintain regular rhythm and rate. There's 2 different types. There's what they call a continuous or an on-demand. Continuous pacers are continuously pace the heart no matter what. On demand means the pacer kicks in when it gets too fast or it gets too slow, and it paces to the rhythm it needs to be at. If a defibrillator is in place, if the patient goes into a ventricular type rhythm, the defibrillator will internally go off. Now, you can be touching this patient and you will not feel the electrical impulse. It's wires directly right to the heart. So you don't have to worry about that. But it's implanted under a heavy muscle or usually a fold of skin in the upper left portion of the chest. However, I have seen them implanted on the right-hand side as well. This technology is very reliable. Pacemaker malfunction can cause syncope, dizziness, or weakness due to excessively slow heart rate. Transport these patients promptly, not properly, both too. If you have to apply an AED to this patient, make sure you do not put the AED pads directly over a pacemaker. Last thing you want to do is shock metal. Automatic implanted cardiac defibrillators, or what they call it AICD, used by some patients who have survived cardiac arrest due to ventricular fibrillation. What they do is they monitor for a heart rhythm and shock as needed. Now, I've seen these malfunction before and continuously shock patients, and they need to be turned off. But we do not have that ability in the ambulance. So you need to get them to a hospital. The external defibrillator vest is a vest with a built-in monitoring electrodes and defibrillation pads worn by the patient. Attached to a they're usually attached to a monitor and uses high energy shocks. Do not touch the patient if a device warns it is about to deliver a shock for these patients. These vests should remain in place while CPR is being performed unless it interferes with compressions. All right. One of the ones it's common, but not very common. And usually your facilities or your services know if there's any in the area. what they call a ventricular assist device, or an LVAD for left ventricular. This is used to enhance pumping of the left ventricle. Maybe a pulsatile or continuous, what they call a non-pulsatile. Pulsatile, you'll feel pulses, continuous, have an impeller inside that actually spins, and it makes like a loud humming sound that you can hear. And these patients are not going to have radial pulses, right? But they're still perfectly fine. The patient or family can tell you more about the device. These patients are usually well versed with what's going on with that device, so they're going to be your big wealth of knowledge. So transport all supplies and battery packs with the patient. Not many facilities can handle LVADs, so a lot of times they'll go there and be transferred out. One of the closest centers for LVADs for us is going to be Tufts Medical Center in Boston. Cardiac arrest is the complete cessation of cardiac activity and absence of a cardiac pulse, and was terminal before CPR and external defibrillation were developed in the 1960s. These are AEDs. They're automated external defibrillators, which identify a ventricular fibrillation and administer a shock with the heart when needed. Most of you should be familiar with these here or seen them before. AED models require some operator interaction. Most have a computer voice synthesizer advising steps to take. So it'll tell you, turn on the, place pads, attach connector, things like that. It'll write down through all the steps. Advantages of AED use: obviously, quick delivery of shock, easy to operate. ALS providers do not need to be on scene for this. They have remote adhesive pads, which are safe to use, and a larger pad area, which is more efficient shocks, which is nice. Other considerations, obviously, through all cardiac arrest patients should be analyzed. Not all require shocks. Okay, that's why it's called an automated external defibrillator. So it talks to you and will assess the rhythm. If the patient is in a systole with no electrical activity, it will not deliver a shock. It only delivers a shock when needed. Or if they have a pulse, it will not deliver a shock as well. Remember, early defibrillation is key. Few cardiac arrest patients survive outside the hospital without a rapid sequence of events. It's what they call the chain of survival. So early recognition and activation of EMS, immediate bystander CPR, rapid defibrillation, basic and advanced EMS and ALS and post-arrest care. So when we talk about BLS CPR and we do the class coming up, you guys will learn more about this during that program. This is what they call the chain of survival. Early defibrillation. CPR prolongs period during which defibrillation can be effective. So again, non-traditional first responders are trained in AED use. So kind of going more over AEDs. We're going to cover AEDs more in depth anyways during CPR class. So I don't really need to hit this stuff too much. So ALS and post-arrest care, having ALS on board, continuous ventilation, better airway management. We can assure blood pressures are greater than 90. If not, then we can always give other medications to assist with that with post-arrest care. We got to maintain glucose levels, so check out blood sugar, and rapid transport to an appropriate hospital. Integrating the AED and CPR, we're going to work the AED and CPR in sequence. So we do CPR for 2 minutes, then we analyze heart rhythm, and then we shock as needed. Back to 2 minutes of CPR. We keep going for 20 minutes or longer, depending on protocol, in hopes we get a rhythm back. If not, then we can terminate CPR in the field. As far as AED maintenance goes, we want to make sure that we maintain as a manufacturer recommendations. All right, moving forward. If an AED failure to report all AED failures to manufacturers and the FDA as well. Follow local protocols for notifying. As far as emergency care for cardiac arrest, make sure the electricity injures no one. So again, if you're going to be delivering a shock, make sure everybody's clear before you press the button. And this is all going to be covered in our CPR course. If they have nitroglycerin patches, make sure you remove them with gloves on and make sure you use a dry towel before shocking. If they have a hairy chest, shave the chest so it increases conductivity. All right, let's go through this here. So begin chest compressions and attach an AED as soon as possible. Witness cardiac arrests and follow your local protocols. So I'm going over this pretty quickly. This is all stuff that we're going to be covering during CPR class. If an ALS is not responding and protocols agree, begin transport when the patient regains a pulse. 6 to 9 shocks are delivered. So again, for us, it's 2 or more. 8, even if you get a shock, you really should be transporting because then they are in a ventricular rhythm that potentially could come back. AED gives 3 consecutive messages every 2 minutes of CPR advising no shock. If you're transporting and a cardiac arrest occurs, stop the vehicle, begin CPR. If AED is not immediately available, call for ALS support, analyze the rhythm, deliver the shock, and continue resuscitation per local protocol. Right, especially if you're by yourself, you're going to need the manpower. All right, so coordination with ALS personnel. If AED is available, do not wait for ALS. Notify ALS of the cardiac arrest. Do not delay defibrillation and follow local protocols. If you get a pulse back, provide oxygen via BVM, 10 to 12 breaths per minute. Maintain oxygen saturation with 95 to 99%. Get blood pressures. Get a 12 lead also, which is not part of this here, but within New Hampshire and Maine protocol. Maintain a 12 lead and go from there. All right. So let's do some review. All right. All the following are common signs and symptoms of cardiac ischemia, except all right. Oh, it's not working. A. All right. Oh, too far. So B. All right. So D, dysrhythmia. Number 3, a 56-year-old man has an acute myocardial infarction. Which of the following blood vessels became blocked to lead to his condition? I'm seeing some B's and some D's. So remember, with myocardial infarction, it's going to be some type of coronary artery. So B. Number 4, major controllable risk factors for an AMI include controllable. All right, awesome, controllable C. Number 5, a patient with cardiac arrest secondary to ventricular fibrillation has the greatest chance of survival if remember we mentioned before, the key to survival, okay, is shocking a patient, defibrillation. So defibrillation is provided within 2 minutes. Number 6, a 59-year-old woman presents with a chest pressure. She is conscious and alert, but her skin is cool, pale, and clammy. Your first step in providing care or treatment should be what? The patient is conscious and alert. Skin is pale, cool, and clammy. Remember, that's signs of deoxygenization, right? So the answer is going to be B. Give oxygen. Pale, cool, and clammy skin shows signs of poor perfusion, which means we got to increase that. It has an increased oxygen demand. So we're going to give oxygen. If a patient with an implanted pacemaker is in cardiac arrest, the EMT should all right. Awesome. C. Good job. Number 8. The main advantage of the AED is perfect. D. Awesome. Number 9. After administering a nitroglycerin tablet to a patient, the EMT should nice. B. Number 10. Nitroglycerin is contraindicated in patients. All right, awesome. A. All right, so before we let you go, I want to show you guys that homework assignment. I want you guys to watch this video. We should just turn off the